हाँ कर दिया मैंने।
Hello. Hello.
Yeah, Dr. Sonal, am I audible?
Yeah, you are audible. And can you just switch on the camera for me? The camera settings are off. Everybody's camera settings are off.
You are not able to open your camera.
Yeah. At my from my side it is on.
Can anyone open the camera? Isn't it working?
Dr. Vaishali, is your camera working?
Camera is working. Avani, uh, his camera is working. Priyanka,
Hear me?
yeah, yeah,
Am I audible?
you are audible, visible.
No, but then the camera it is not starting from my
Yeah,
side.
it is saying there is a red line on it as in stop.
No, but
There is a red
Tumita is
line on it.
visible. Tumita Bhagwat is also
I'll
visible.
What I'll do is I'll log off and I'll come back
Yeah,
again, but then
please.
it is not visible.
Yeah, because from my side I'm not able to do it.
His camera visibility is not there. Just check in the setting for me.
Dr. Chetana, Dr. Aparna, Dr. Vaishali, could you please open your camera, just see whether
It's
uh,
not happening, sir. See, then I went into the settings, I went to the video also, and it's not happening.
Yeah, it's not happening
Because
from.
it is showing passive to me. It is not showing as active. So that means there is some problem from your side. Let me try connecting from the phone and check once.
Dr. Nural, can you just switch on the camera for me?
Dr. Vaishali is also visible. There are many.
Yeah,
There,
but then it is happening, so I will just one. I will log off from the. Okay. I logged off from the laptop.
Hmm. Yes. Yeah, yeah.
Yeah, now this is.
Uh, should I try from the laptop once now? I think you have come, so maybe the setting improved. Should I try?
Once again, you can try.
Yeah, Dr. Nural, is my voice, am I visible now? I think from the mobile I'm
Yeah.
visible. The only thing is that, is there a echo now? Because I'm keeping my laptop on for some reason. So is there any echo?
No, we are not
No.
hearing. Yes, yeah.
No echo.
Okay, but my voice is loud and clear.
Yeah, it's a very loud and
Very
very
loud.
clear.
Okay, I know.
Your voices are always be loud and clear.
Sorry. Yeah. Okay.
So are you from the phone only, right?
Yeah, this laptop thing is not happening. So I'm logging in from the phone only. So let me just.
Yeah,
Setting.
because for me
Let me-
also it is not happening.
Let me just do the setting in a way that.
Matlab the video thing. Last time there was an issue with the audio. Now they're having an issue with the video. I think now it should happen because it could echo for a minute.
Okay, this is better, right? This that way I was sleeping. Okay, fine, fine, fine. I'll have to hold the camera in my hand only now then. Because
Oh
I'm
my God.
for what do you
Dr.
call the.
Sonal, you try once again with your laptop. Maybe, it would be visible. Just you try once.
Okay.
Dr. Nurul, if you could just let me in.
Okay.
From the laptop, I tried to join.
I think this is happening because you have the app in two devices. When you have downloaded the app in two devices,
No, I'm from the browser. I'm logging in from the browser. So that should not happen.
because I have the app only in the laptop.
No, but I have done this earlier also many times.
Yesterday
It has
only we were
never
there, right? We were online, right, on the same
No,
thing.
but again, this was a problem. Anyway, I'll leave from the laptop. I think it's better. I'll be on mobile only.
Dr. Nurul, let me in from. Okay, yeah.
You are in.
No, there is some setting issue here. Okay, beta. Okay,
Yeah.
okay. I think I'm visible now. Yay, done. Okay. All set. Hi, Dr. Rumpa. Your
Hi,
mic is off.
Sonal. Hi there and hi everybody present here.
Dr. Rumpa, your mic is off.
My mic is off. Hang on.
No, I could hear
The
Rumpa.
speaker,
No.
maybe the laptop setting.
Wait up. Give me a sec.
Dr.
Hi,
Rupa,
Dr.
you are
Sumita,
audible.
Dr.
No, but
Darshita,
Dr.
Dr.
Rumpa is
Nural. Very
audible.
good
I
Oh,
can
afternoon.
it's
hear
full.
her.
Can you hear me now?
You were audible earlier also.
Can
Yes.
you hear me now?
Yeah, Dr. Rupa, you
Yeah.
are audible.
We can hear you.
Dr. Nural, have you muted everybody? Are you bored with the females right now itself in 1 minute?
Am
I'm
I
not on
audible
mute.
now?
Can you hear me?
I cannot hear anyone.
So that's a setting issue with your connection.
Yeah, because I can hear you, Sumita. Can you
Okay.
hear me?
Yeah, now it is all right. Now
Vaishali, I can hear you.
everybody.
Oh, great. How are you, Rumpa?
All good, Vaishali. Am I audible now?
Yes,
Absolutely.
loud and clear.
Absolutely.
Okay.
But my problem is now I'll have to keep holding the phone in hand.
What what jugglery we are doing, right?
Yeah,
Okay.
that's all. But then I don't know why it's happening with this link only. One last try. I hope we are not live anywhere.
We are live on YouTube right now.
Oh, are we? Okay. Anyway, there are always technical issues.
Yes. First 5 minutes, ignore everybody. So I'm expecting more participants to join in. Right now, I think the paper presentation participants have already started joining in. We have a good number here. At any given point, I think we have a setting of only 25 to be visible. The rest will be there, but they won't be visible on the screen. I see everybody in the shades of red and pink for Women's Day. Happy Women's Day to all.
Dr. Nurul, could you please try letting me in once again? One more last time.
Yeah, I think he is not there. So let me just see if I can take you in.
I got logged out.
Another 2 minutes and then we should go live now. So, Dr. Nural.
Can you hear me?
Yeah, this is your laptop, is it, ma'am?
Yeah, now
Wow.
I have a laptop.
Perfect, perfect, perfect. So now everybody's laptop screen as well as the mute and unmuted and all videos are visible. Everything is on. Okay, Dr. Darshita, you will be made the co-host now.
Yes, doctor.
Yeah. Yeah, you can speak, Dr. Darshita. You're visible.
I'll start by introducing Dr. Sonal first. So, welcome everyone to the third season of the Pink Dental Congress, where innovation meets elegance in the realm of dental care. Let me introduce to you all our chairperson, Dr. Sonal Yerpude, a distinguished private practitioner hailing from Mumbai. She has an experience of over 2 decades in transforming smiles and relieving orofacial discomfort. With a focus on full mouth rehabilitation and meticulous orofacial pain management, Dr. Yerpude's visionary leadership has brought forth the Pink Dental Congress, promising a symphony of knowledge exchange, dental excellence, and a celebration of life beyond dentistry. Join me in welcoming Dr. Sonal. Happy Women's Day, everyone.
Thank you. Thank you, Dr. Darshita. Yeah. Hello, everybody. I'm Dr. Sonal Yerpude, and I would like to welcome you all to the Pink Dental Congress third season in association with MedSkills and National Health Academy. This Pink Dental Congress is an amalgamation of all the dentists, women dentists, I would say, who have not only created a niche for themselves in dentistry, but have also had this perfect work life balance. So when I talk about this conference or this congress, how this theme came into the picture, actually at the fag end of January, Dr. Nural came to me asking me that, okay, we are going to be organizing a congress and come up with a theme with a set of speaker. It's your baby, your child. I said, okay. And that day I was traveling from attending a one day lecture with my mentor, Dr. Davis Thomas. And I had a good 45 minutes time. In that 45 minutes, I had made a set of all the speakers with all the specialties in dentistry. It was a typical to be congress which would have a prosto endo session and all of the typical specialties of dentistry. And it happened so that when I reached home, I saw my 18-year-old enthusiastic daughter telling me about her day the moment I entered the house. And it really hit me because I saw myself when I was 18 years of age. And one thing that it hit me like a bullet, I would say, is have I done justice to that 18-year-old self of mine who had come to this city with all the dreams and all the aspirations and whatnot? And have I done her proud? Am I proud of that 18-year-old or 20-year-old life of mine as a dentist? And what hit me is, yes, I am proud. Let me take a pat on my back. So what transformed me to making this congress is a different story or a different with a coming up with a different theme was that one lightning bolt which struck me that yes, we have life beyond dentistry, and that is something that is fulfilling us today. So every life has a story. I always say that every smile has a story, every life also has a story. When I say that every life has a story, believe that when I talk about myself, what makes my day special? What is that special moment I wait for? Is it that when I place the best of my implants or I do the best of the rehabilitation? Or is it that when my patient smiles after having a chronic pain issue and they are smiling and they are saying they're pain free? Yes, that gives a different kind of euphoria and enthusiasm and something to look forward to. But there is more to it. I really wait for that 1 hour of time which I spend with my family, maybe before going to the clinic or after the clinic, when I discuss about my whole day forward and day that has passed by. So that is what kept me going, keeps me going. That's what I would say. The nuisance, the whatever confusion that happens throughout the day or the conflicts that happen throughout the day, that 1 hour rejuvenation with my family is the time wherein I develop as a human being in a way that I can fight the world or I face the world better the next day. So if I have to tell my 18-year-old self that all the hardship, heartbreaks, and all the challenges that I am going to be facing or I will face in future will be the building blocks of the person, building blocks that will make the person I am today, the resilient person I am today. I am known to be very bold. I am known to be very upfront to the point to which that I am called that, okay, she's very blunt in talking. But yes, the person I have become today, maybe that's an amalgamation or that is an amalgamation of all the hardships or all the challenges that I have faced, and I've become this person today. So I'm proud of what I am today. So can I say that when in my 60s that I am proud of myself when I was in 40s? So this transformation thought process was the theme for this congress. Let's make a journey. Let's I understand the destination is very important, but let's have a journey of our life which is so fulfilling. Let's get inspired by some people who have already lived this life, who are at the brim of starting their career, who have already enjoyed this phase of life. So when I thought about all the speakers and all the themes what I had in my hand, I had already charted them. I said no, these speakers have something totally different to talk about. There is more to their life than this dentistry. And that's how this whole concept of Pink Dental Congress came into picture. For me, if you ask me, I'm a very romantic person at heart. I love reading books. I become a part of that story when I am reading or listening to. So let me also become a part of these 24 divas or speakers who are going to be talking today. They have something to offer to all of us. They have gone through hardship, they have gone through all the challenges, whatever you can talk about, or they may be going to it. So let's inspire each other. I would call this Pink Dental Congress as a big web series, a Netflix web series or a Pink Dental Congress web series, which will have 24 short stories, which will inspire you. At some point in time you will relate to them, at some point in time you will cry with them, at some point in time you'll laugh with them. And this is what womanhood is all about. I am not a person to dwell in my past, but yes, photography has taught me that when we look back at those memories, Facebook has a very, very beautiful feature of memories wherein we all can go back and see our memories, and that really rejuvenates my day. So I make it a point that every day I click at least 2 photographs throughout the day, in that day, that I have a collection of. Though I have a 2 GB TB full of data with me, all full with photographs, and my husband is always behind me. Why are you doing this? I say, you will understand when we reach our 60s. You will understand what I have done. There is always an album to go back to for each day. So this is what pulls me along. Like, okay, understood. Dentistry, monetary gains, we need to have them. That is the core of our life. But we have a life beyond dentistry. You know what? There's one very particular uh, quote. I'm not a very person who gets motivated by motivational speeches by others, but there's a quote which always stuck with me, and that says that in this world, it is a man's job to respect a woman, but it is a woman's job to give him something to respect. What I say by that is that in this whole world, you need to have your own identity, your space, and respect yourself enough so that others start respecting you. With this theme in mind, let me welcome you all to this Pink Dental Congress, and wishing you all a very happy Women's Day first. I would like to start this whole Congress, and there is a lot much of surprise waiting for you. I will not steal the thunder from all the speakers that we have today and tomorrow, or this 3 days. So I would invite you all to this 3 days of web series, which will be back-to-back web series. I would say a binge watch series of 24 beautiful stories, beautiful lives, which will really make a difference in your life. With this, I would like to welcome each and everybody, all the participants, jury, and the chief guest for today. And thank you all for making this Congress. Actually, I got all the speakers finalized within 14 hours. And that was like I was so overwhelmed by it. Everybody was like, Sonal, yes, you are there, we are coming. Dr. Rumpa, अरे तू कर, मैं हूँ. So I got that kind of response from everybody, and I was so overwhelmed by just that response. That says it all. We don't need Saas Bahu sagas over here. We are in this world which is way beyond. We have already stepped way beyond all these sagas or hatred stories or hateful stories or hurtful stories. We have got enough opportunities in our life. We have already progressed enough. So let's make a world that is more fulfilling for us, for our future generation, and make ourselves proud when we look back at our life 20 years from now. Yes, I did something good. So with that, I would like to welcome our chief guest of that for the day, Dr. Rumpa Vig. Actually speaking, Dr. Rumpa Vig needs no introduction. Frankly speaking, in any conference, if you go where there is noise, where there is laughter, and where there are females hovering over, or males trying to hover over somebody, and that is Dr. Rumpa Vig.
Oh my
She is a person who has made a lot of difference in everybody's life by just being herself. And to talk about her curriculum, or whatever her academics and all that, it is, I mean, I would say this whole page I'm carrying, it carries only, talks about only Dr. Rumpa Vig, and I would still fail talking about whatever she has achieved today. She's a mentor at par. She's been mentor for NYU, right from NYU to Pulp Dent, and she's been a keynote speaker for all the international brands you talk about in aesthetic dentistry. All of them talk about Dr. Rumpa Vig and how you should be following her path. So, and to top it all, this is her career. This is her life in dentistry. But to to mask all that, she's also a Visharad in Sangeet from Gandharva University. So that says a lot about her. She is a person who has taken dentistry, her life, and every person along with her to a different notch altogether. So welcome, Dr. Rumpa Vik, and please inaugurate this Women's Dental Congress. I'm glad that you are a part of this Congress, and in such a beautiful way. And you're looking very beautiful, ma'am. I mean, I'm always, ma'am, we cannot hear you.
No, I didn't speak loud actually because
Okay.
you're on the mic. But yes,
Okay, ma'am.
as soon as you give me the signal, I'm good to go.
Please go ahead, ma'am. Please welcome Dr. Rumpa Vik.
Thank you so much. And a very good afternoon to all of you. Wonderful, joyful people. And I thank Sonal for inviting me as the chief guest of this wonderful Pdcon 2024, which promises a whale of a difference in the thought and the concept. And I must thank Sonal for giving me the chair of this chief guest, because she had asked me for a lecture. But at that time, I was traveling and I could not get back to her immediately. And so I said, Sonal, like she said, tu kar, main hoon. So isme, when I become the chief guest, I can listen to all those 24 fantastic OGG. OGG means Original Girl Gang. Ashwini, if you're there, hi to you. Dental Divas, the Original Girl Gang, salutes to you for forming this, because here we can be ourselves. We don't have to, take a peek here and there, and we can just be ourselves. And it is really a confluence of greatness of many kinds as we are gathered here. Today is Women's Day. We honor the women in our lives who essay their many roles with strength, dignity, verve, and dedication. Whether the field is professional or whether it is social, whether inside the home or outside it, women are engendering excellence and achieving great success. Today is also Mahashivratri. This auspicious festival has a deep and significant lesson. It is an internal, immutable truth that divinity is bestowed upon men and women both in equal measure. Neither is more nor lesser. Each needs the other. They are complementary. And one thing I must tell you about Mahashivratri, while we were doing our graduation, I'm a product of GDC Indore. So the girls hostel, not women's, we were girls but then. So the girls hostel and the boys hostel had a common wall, just a wall, okay? The girls hostel was separate and we had to share the rooms in the medical hostel. We didn't have a separate dental hostel in those days. So all the girls from the hostel would go to the nearby Shiv Mandir with thalis and diyas and all, and the boys would just be "Hi, ye kabhi mujhe na mang le." So it was a huge tension there. So that was Shivratri by then. Now coming to the reason why are we here. Pdcon 2024 is a magnificent initiative to showcase some of the very best that Indian dentistry has to offer. Other than dentistry, it is that personal touch, that heart, that soul, which brings along with the 24 wonderful OGG, my Original Girl Gang, who are about to be here. And we have these power-packed sessions featuring the latest principles, tools, techniques, materials, and much more. It promises to be memorable, full of learning, good ideas, and above all, tons of fun. So let us all chase that star that shines forth and calls out to us. All the very best to everyone. Over to you, Sonal.
Rumpa man, one wish, one request. If you are there and you don't sing, that really doesn't come articulate the whole process. So one line, ma'am, for the women today.
I would have, but mera gala baitha hua hai. Can you hear the difference in my voice today?
I can hear that. So next time one Sangeet session with you, ma'am.
Pakka. Arey Vaishali baithi hai na, head of all those sessions.
We
need to organize something. I'm there.
This is one reason every singer gives. So no excuses.
सच्ची खराब है, सच्ची खराब है. नहीं तो मैं पक्का गा देती. मैं गाने में मेरे को बिल्कुल हिचकिचाहट आज तक नहीं हुआ है. Seriously, my voice is totally clogged today. Totally. Okay. Now, Vaishali, you must take this up and do something later on. Over to you.
So the theme today we have is paper presentations by faculty and the UGs and PGs. And for that, we have our jury with us. We have two beautiful professionals, or they were teacher, they are mentoring, they are the people whom everybody is like a little scared of. All the students are a little scared of, and I've heard that, let ma'am be little lenient with me, let ma'am be little soft with me, and that's the impression they carry. So let's break their impression now, and let everybody know the softer side of these two beautiful speakers and jury here. We first have Dr. Sumita Lele Bhagwat. She's a professor, PhD, and postgraduate guide in Department of Conservative Dentistry and Endodontics in D.Y. Patil University, Navi Mumbai. And she's an affectionate academician, as we all know, and she's dedicated herself to the pursuit of knowledge and innovation. And she's known for shaping the minds of future dental professionals. And I have always noticed that she always posts the photographs with her students on Facebook, if they have won any contest or they have got gold medals and all, and she's always proud about them. So I'm sure we have a very good jury here, and she will guide the participants well. And the second jury we have our beloved Dr. Vaishali Das. She's a consultant oral and maxillofacial surgeon at Bhaktivedanta Hospital. She's also the founder of Orthodontics Mumbai. That is a unique concept in itself. And just yesterday, I think she was felicitated by IDA Dental, IDA, I think Mumbai branch for her accomplishment. She is an affectionate oral and maxillofacial surgeon and a mentor, as we all know. And her orthodontics is something which has provided a platform for all the artists, dental artists, be it male, females. And she has been a pioneer in this is a one of a kind, and I've not seen anybody really having a passion is one thing, but putting it into use for others, like providing a platform for others, it means a lot. So welcome our jury, Dr. Vaishali Das and Dr. Sumita Bhagwat. And here we have our first paper presenters. Are they online, Doctor? Dr. Nurul?
Yeah, Dr. Darshita, I think she will start, no?
Yeah. So Dr. Darshita, the stage is all set for you. Dr. Darshita, your mic is mute.
Yes.
Yeah.
Good afternoon, everyone. Wish you all a very, very happy Women's Day once again. I think for me, women are like the heart and soul of every family. You give the woman a house and she has the capacity to make a home. You give the woman veggies and she has the capacity to make a meal. But sometimes we get uljhaufied in the multiple roles that we have to play on day-to-day basis. We sometimes forget our why. And in quest of making other people happy, we choose others' happiness before us, and we land up emptying our cup. Now, today I want to speak about my journey from the time that I was a little girl, and how the 3 C's that I'm going to be talking about today came into my life, and how I reached my final C, which I will be talking about. So when I was 15 years old, I was teased in my school. I did not have a good set of teeth, and it made me feel that I wasn't good looking. I would cover my mouth when I would smile or speak. I stopped participating in school competitions and even family gatherings. And my mother understood that there was something, that was bothering me. And mothers are, thank God for mothers, right? So one day when I came home from school, I was crying and I asked my mom, Mom, is my smile so bad? And she just looked at me, and you know how women are so action oriented. She just picked up the phone and she called her friend and she said, I want to know the number of the best orthodontist in town. That very evening, the appointment was scheduled. We went. In the following week, my treatment was started. After 9 months of my braces treatment, I remember the day, which was the 12th of June in the year of 2000. It was a Monday evening. I came back from school. I was excited. Yay, today my braces are going to come off. And after my braces came off, the dentist handed me a mirror and went to the other room to check on another patient. When I saw myself in the mirror, I did not believe what a set of aligned teeth and could do to your smile, could do to your confidence. That was the day I came across my first C, which is clarity. In my mind, it was so clear that I'm going to be a dentist. I'm going to be a girl sitting on that side of the chair where the dentist sat and make the person who's not feeling confident about themselves or their smile feel like how I felt that day. That was the day that I came to know that my existence in this world is for this purpose. So that was my first C. I did not, after all, then my exams happened. I did not get admission in Mumbai. I decided to take admission in Nasik in Mahatma Gandhi Vidya Mandir College. And the day my parents came to leave me in the hostel, they saw the hostel room, and coming from a privileged business family, my father looked at me and he's like, are you sure you want to live here and you will be able to live here? And I was like, Dad, मैं dentist बन के ही घर पे आऊंगी. Don't worry. He used to keep telling me, we are just a call away. If anything happens, please give us a call. We'll come and, pick you up from here. And I said, nothing doing. I've come here to be a dentist and I'm going to be a dentist and I'm going to come back home. And that's what happened. I finished my graduation in the year of 2009. Thereafter, I went to NYU. I completed my PG diploma. In the year of 2011, me and my husband, Dr. Manan, we opened our clinic. We got married. We had 2 kids. And then the lockdown happened. Well, that was like one of the most dreadful periods, I think, in our life because our profession suffered the most. It was one of the most riskiest profession. And I remember for 7 months, I had not seen a patient. And in that time period, I know how my mental health was affected. The responsibility of 2 kids, the overwhelming responsibility of the house, which I wasn't very used to, that took a toll on me. And that's when I think all of us women, we are gifted with empathy, we are gifted with multitasking, we are gifted with so many good things, but somewhere we are also gifted with this negativity bias that we have. And in our low point in time, low phase of our life, we get into a victim mode, and that's what I got into at that time. And thanks to my life coach, Pooja Puneet, she told me and she introduced me to the next C, which is choice. So she told me that, you know what, Darshita, your life is in your hands and you need to be the driver of your life ahead. And you need to make choices in congruence with what you feel needs to be done on a day-to-day basis to feel that you're making the right choice that is working towards your purpose. And the next C, which is working towards. So these are the 4 things that I personally incorporated in my life. Number 1 was spending quality time with my children. In fact, when Dr. Sonal said relationships are, the number 1 parameter of happiness, honestly, I get my happiness from my children. And the 2 hours of the time that I spend with them, I know that I'm more rejuvenated. And, that's a part of life that I'm so excited about as soon as they come back from school. The second thing that I chose was prioritizing my sleep. 7 to 9 hours of sleep on a daily basis. We all in the lockdown got hooked on OTT, and don't even get me started on Instagram. But people who know me in the past 3 years know that at 10 p.m., my phone goes on flight mode. And I started prioritizing that rest, which is so required. I started prioritizing the food that I ate and the me time, that the much needed me time that, gets missed because of the multiple roles that we play. So I chose to do yoga or workout. I chose meditation. I go for a walk listening to my podcast. So before the kids go to school, I have some time, and in the middle of the day, I find some time to kind of, so prioritizing, that was the third choice that I did, prioritizing that me time. And last, luckily for me, being a dentist, being a BDS, I had the opportunity to do all dental procedures under the umbrella of dentistry. But there are certain things, there are certain procedures which really, we look forward to. And I realized that I loved implant dentistry. I love treating patients with orofacial pain. I loved doing smile design. And on a daily basis, when you do what you love, there is nothing more fulfilling that, that literally fills your cup, kind of a thing. So these are the four choices that I made on a daily basis, so that I feel like I have made the right choice. And honestly, coming to my third C, which is contentment. So committing yourself to walk on a journey which is in direction of your purpose and in alignment with the choices you make on a daily basis towards happiness is honestly, for me, the path to contentment. And I wish, like today on, this Women's Day, everybody who's present here takes that one takeaway from this 7 or 8 minutes that I have and incorporates that one C in your life, and you can see the difference it will make. Let me ask you something. Today, when we wear our scrubs and we enter our operatory, is that in alignment with your why? Is that in alignment with your purpose? If yes, then I'm sure you make choices on a day-to-day basis that will lead you to a part of contentment. Thank you so much. I hope I'm in time.
Yeah,
Yes.
Dr. Darshita, that was a lovely presentation. And yeah, what you spoke about the three C's, that is what we all are sorting after, we are working for. Only thing is that you didn't share your screen, dear.
Oh, yes.
Okay, so no
I
issues, no problem. It was lovely watching you present the presentation and all. It was lovely. Thank you so much. That was Dr. Darshita. Jury, this presentation from here on are from the faculty, and they will not be marked for the contest. So we have around 9 or 10 of them which will not be marked for contest. I will let you all know when the presentation starts for the students and UG PGs. So from there onwards, you need to start marking up. Okay. So we next have Dr. Ashwini Narkar with us. Is she there? Dr. Ashwini?
So
Dr.
Ashwini
Nural?
Pujari. Yeah, Dr. Ashwini Pujari.
No, no, no. We want Dr. Ashwini Narkar, sir.
She's not there in the room.
Okay. Dr. Astha Dureja, are you there?
Oh, she's there.
Yeah. Can you make her the presenter now?
Yeah, I have made
Astha
all
Dureja is a
the.
faculty, so we are not considering this presentation for contest.
Hello.
Yes, Dr. Astha, can you switch on the camera?
Yes, 1 second. Am I audible?
Yes. You can start sharing your
Okay.
screen.
Yes, sure.
All the best, Doctor.
Thank you so much. 1 second. Hello. I'm so sorry.
Dr. Sonal, you are on mute.
Okay, Dr. Asta, do you have a share screen option down?
Yes. Actually, I wasn't able to kind of share my screen. I exited the meeting. I'm just going to share my screen now. I am not able to go to my presenter's screen.
Go to the presentation. Go back to the presentation.
Yes.
Manually, you can do it then in that case.
Okay.
Your slides are visible, Dr.
It's visible?
Yes, it's visible. Go ahead. Start.
Okay, great. On this auspicious occasion of International Women's Day, I stand before you with immense joy and gratitude as I present my first paper as a member of our esteemed dental community. Today holds a special significance, not only because it marks a milestone in my career, but also because I have the privilege of sharing this moment with all the incredible women dentists gathered here. So, good morning, dear jury. I'm Dr. Astha Dureja, and I'm here to present my research paper, which is the effect of various chelating agents on the wettability of a bioceramic and a resin-based sealer. Root canal procedures are one of the most commonly performed procedures on a day-to-day basis. It's not just limited to cleaning and filling the root canal spaces with obturating material, but it's about creating a fluid impervious seal and providing a 3D obturation, which does not lead to any chances of reinfection. How do we attain that? Knowing and choosing the material is as critical as knowing the procedure. But with so many of these materials available in the market, which one do we choose? Are we really aware of the properties of the materials that we are using in our operatory? Do we really have that awareness? We know the time-tested and gold standard materials which have been used in dentistry and endodontics, especially sodium hypochlorite, using EDT as a final irrigant, using a resin-based AH plus sealer, which is the most commonly employed one. But do we know that hypo and EDTA cannot be mixed or used together one after the other without an intermittent irrigation with saline? Do we know why do we use EDTA in the first place as a final irrigant? Even if we know these answers, can the same irrigation regimens be applied to bioceramic materials? Is it a one-size-fits-all? The more we question, the more we strive for the solution. And this is what a mind of a researcher looks like. And this is what makes us find solution to the most unique research questions. I come from the same place and hence performed this original research where I aimed to study how the different irrigation regimens have an effect on the wettability of a resin-based and bioceramic sealer. This study was an in vitro study. We all know the hierarchy of evidence wherein we first perform all the studies in the lab or in vitro to consider it fit enough to be performed, on humans. And this is the protocol I followed. And let's see the materials and methods. The irrigations that we used were sodium hypochlorite with different chelators, namely the gold standard EDTA, along with malic acid and HEDP. Each of these irrigants react differently and induces microscopic changes on the surface of the dentine. Now, EDTA, even though widely accepted, has disadvantage like it has the inability to flow in the apical 1/3 of the root canal spaces. It has cytotoxicity. Malic acid helps in overcoming the drawbacks of EDTA. 9% HEDP is a mild acid. It does not alter the micro hardness of the dentine, but in spite of its mild nature, it adequately removes smear layer out of the root canal dentine. The sealers that are tested in the study were AH+, which is the gold standard resin-based sealer, along with CeraSeal, which is a bioceramic sealer and which is grown rampantly due to its bioactivity and biocompatibility. Wettability of the sealer is an important parameter to ensure a good adaptability of the sealer on the intraradicular dentine, especially in difficult to reach areas like ramifications, fins, deltas. Moving on to the materials and methods, after obtaining the institutional review clearance, a total of 44 tooth samples that were devoid of any fractures, resorptions were taken as a part of the study. These were then decoronated. The roots were sectioned into half to obtain 88 samples. These were divided into 4 groups based on the irrigation regimens, making it 22 samples per group. Group 1 had 17% EDTA, Group 2 had 7% malic acid, Group 3 had 9% HETP, and Group 4 was distilled water, which was used as a control group. The samples was first irrigated with 5 ml of 2.5% sodium hypochlorite, followed by 1 ml of chelator. Post completion, each sample were rinsed by distilled water to remove any precipitate that would have been left after the irrigation regimen. These 22 samples were further divided into 2 subgroups depending upon the type of sealer used. All the A groups used CeraSeal sealer, while the group B's used AH+ sealer. The wettability of the sealer was measured using contact angle goniometer. Contact angle tells how well the material adapts onto the surface of the dentine. If the angle formed is very less, the wettability will be better. Whereas if the angle is large, it has low wettability. The contact angle goniometer has a flat horizontal stage or a mount where the samples are kept. It has an illuminating source. It has a protractor eyepiece. 100 grit paper followed by 600 grit silicone paper was used to clean or clear the roughness out of the surface so that it does not alter any contact angle value. Since volumetric change is also known to affect the contact angle, a micropipette was employed to dispense 0.1 mm of the sealer. 3 drops of each sealer was used onto every tooth sample, and the camera incorporated in the equipment took the images of the contact angle formed. Coming to statistical analysis, SPSS 21 was used for the analysis. Descriptive statistics was used for taking out the mean and the standard deviation. Comparison between the sealers was done with independent t-test, and multiple comparison between irrigants was done using two-way analysis of variance. Coming to the most awaited part, which was the result, it showed that irrespective of any irrigation protocol, all had a beneficial effect on the wettability of the sealers, be it CeraSeal, be it resin-based AH+ sealer. The use of 9% HEDP as a final irrigant had the most favorable effect on the bioceramic sealer, followed by malic acid and EDTA, where EDTA performed least favorably. Coming to AH+ sealer, malic acid performed the best, followed by EDTA and HEDP, where HEDP performed least favorably. Comparison of the sealer showed AH+ sealer to show better wettability compared to, in all the groups, compared to CeraSeal sealer. Now moving on to discussion, CeraSeal is a calcium silicate based material, and by literature we know that it does not benefit from the calcium chelating ability of the irrigant. Therefore, the irrigant that does not hamper the calcium from the sealer will perform the best, because calcium also plays a very crucial role in the setting reaction of bioceramics. HETP is a bisphosphonate that gets highly absorbed by the hydroxyapatite and increases the surface energy of the substrate. Higher the surface energy, the better will be the flow or the wettability. This would have probably been the reason for its increased wettability after the use of HEDP. 17% EDTA showed the least favorable result due to the formation of calcium complexes, maybe because of the bioceramic sealer. Moreover, compared to malic acid, it demonstrates more detrimental effect on the hydration properties of calcium silicate. Coming to AH+ sealer, malic acid gave the most favorable outcome. this is because of the mechanism of action of the resin sealer, which is different than that of bioceramic sealers. So resin sealers bonds by mechanically interlocking into the collagen in the dentine by penetrating inside to the dentinal tubules. The demineralization of the short duration in malic acid led to pronounced opening of the dentinal tubules, leading to increased surface roughness. Now, according to Wenzel model, the more the roughness of the substrate, the better is the wettability. HEDP, on the other hand, due to its mild nature, would not have led to such pronounced opening of the dentinal tubules, leading to lesser roughness, and hence would have not performed as well as malic acid. Between the two sealers, we know that AH plus performed better because maybe it takes longer time to set, which would have given it more time to flow. It would have also led, because of its high creep capacity, it would have led to closer adaptation onto the intraradicular dentine. CeraSeal, being a bioceramic sealer, sets in the presence of water. So when we had blot dried the samples to mimic the oral condition, the setting reaction would have started as soon as the sealer contacted the intraradicular dentine, which would have given it less working time and hence lower wettability, which is in accordance to CeraSeal's manufacturing instruction also, which claims that it has the high washout resistance compared to any other sealer. Coming to the scope, this in vitro study concludes that different irrigating regimens with different sealers, it leaves us with the scope to perform research as the clinical outcome may vary considering altered method of sealer placement and irrigating mechanics. Therefore, I would like to conclude by saying that everything is not a one-size-fits-all. Understanding the material science is very critical. Backing of literature before each clinical step would lead to utmost patient care in its true sense. Let's hope to study more literature and propose research questions that can falsify or accept the claims made by the manufacturers. Thank you so much.
Okay, very well presented, Dr. Astha. And Dr. Vaishali, do you have any question for Dr. Astha? Can you unmute yourself? Yeah.
I would rather pass on the question to Dr. Sumita because she can handle the context and she will be able to
Yes. Dr.
ask better.
Dr. Sumita, ma'am, are you there?
Yeah, I'm here.
Yeah.
So, Dr. Asta, my question to you is, what were the difficulties that you encountered while carrying out this study?
Ma'am, the difficulties carrying out the experiment, which is also one of the limitations of the study, was that generally when we are performing root canal biomechanical preparation, it makes the surfaces of the tooth sample more concave because we are increasing the file size and it becomes concave. Whereas for us to in the in vitro study to evaluate the contact angle on the substrate, we needed a smooth and flat surface. So to achieve that kind of flatness with the entire process was one of the most difficult parts of conducting the study.
Were you able to get some semblance of a flat surface?
Yes, we did. We did.
Good.
Okay. Thank you, ma'am.
That's all.
Yes.
Okay, so now we have our next speaker in line. Yeah, do we have Dr. Chetna K here?
Yes, ma'am. Good afternoon.
Good afternoon. Dr. Chetna, you can start sharing your screen now.
Yeah, just a minute, ma'am.
Your camera is off, madam. Yeah, you're visible now. Start sharing your screen.
Is it visible, madam?
No, doctor. Have you clicked on the
Sorry.
share screen button?
Yeah, madam. Actually, PPT is open here in my laptop.
Have you given the access to the screen on the laptop?
Sorry, madam.
Everybody, there's a favorite request to change your name to the registered name so that we all can identify you. Don't just log in as a host or guest or some other kid's name or husband's ID. So please log in from your ID so that we know actually who has logged in.
Dr. Chetna, you have logged in with the two, devices. That's
So
why
now
your
is it
face appeared.
available, sir?
Yes, yes. Okay,
Yes.
go
Yeah.
ahead.
Go on the full screen, sir. Ma'am, go on full screen. Dr. Chetna, please go on presenter's mode.
Yeah, is it visible now, madam?
No, not as a presenter mode. Yeah, down.
Dr. Chetna, can you just go to slideshow?
Yeah, go on the slideshow.
Okay, okay,
Go on
madam.
slideshow and just
Go on
start
right. Go
playing
on.
that.
Go
No,
on
not
right.
that one.
There.
That-
Go on the
no,
right.
no, no.
Go on the right side, ma'am, near the minus button. Yeah.
Slideshow,
No.
yes, madam. Yeah.
Yeah,
Perfect.
yeah.
Your
Is
time
it
starts
visible now,
now.
madam?
No, your time starts now.
Okay. Good afternoon, everyone. Happy International Women's Day to all the beautiful ladies here. Yeah, I would like to thank the forum Pdcon 2024 for giving me an opportunity to present and share my thoughts. Yeah, coming to the presentation, as there's a general saying that childhood comes twice in the life, means even in the childhood and the geriatrics are also treated as children. And as the age progresses, the elderly also become child. It might be even the emotionally or also orally when we see even as a child that doesn't have the teeth, and even in the geriatrics we don't see teeth, that is the complete edentulism. Even though we cannot give them back the original teeth, we can recreate their smile and also give back their function so that they can chew properly, eat properly, and maintain their health. So but when we say fabricating dentures won't be always a simple task, so it won't be as we talk also. So there are so many cases which has to be treated in a different way also, not always the conventional way. So myself, Dr. Chetna K, Senior Lecturer, is here today to present my case reports on the prosthodontic rehabilitation of patients with hyperplastic tissues. These are my contents. And when we say an edentulous patient's residual ridge always serves as the foundation for the fabrication of a complete denture. When we have in a dentulous case where teeth are there, the scenario is completely different. Whereas it's in a complete edentulous case when the patient has no teeth at all, so his residual ridge forms the foundation. So for that foundation to be proper, it has to be treated well. And the improper denture use, if the patient is already a denture wearer, causes hypertrophy and inflammation of the basal seat, which results in the formation of flabby ridges. Here we can see the flabby ridge. The flabby ridge tissues are nothing but the mobile hyperplastic tissues, which are commonly found in maxillary anterior region. It is usually associated with a maxillary complete denture where it is opposing the natural mandibular anterior teeth. And we have a syndrome named as combination syndrome where we see this, the mandibular anterior teeth are present and the maxillary completely edentulous. When we see microscopically, the basal cell layer hyperplasia is seen in this. What happens is when we make the impressions, so usually we make in the mucocompressive state, whereas when it's a hyperplastic or the mobile tissue, the impression making has to be a little bit altered. That is, we have to go for the mucostatic impression. So when the proper technique is not used to record this displaceable tissue, the tissue beneath will bound to rebound over the denture, which causes the denture instability. Since it's the unstable denture, it hampers both the function and appearance of the patient. So here in our cases, we have seen that a special technique is used to record the tissues. Coming to the case reports here, a female aged 80 years came to the department, and when we took the history, she was wearing the denture since already 10 years. And so we started with the primary impressions. Here we can see we have gone with the irreversible hydrocolloid impressions. And then rather than that conventional custom tray, we have done the flabby tissue was marked with the indelible pencil on the maxillary impression. Then both the impressions, as we made the primary cast, then the spacer, and for the special tray was fabricated for both the arches. Here, for this special case, what we did was the special tray, a window was created in order to record the flabby ridges. Here you can see the marking where the window is created. After that, what we did was another special tray was made, and then the window, it was attached to the window through the die pins and the perforations. Next, we went on with the border molding for both upper and lower, and then a light body elastomeric impression material was used to make the impressions. As we all know that light body impression material seems to be a mucostatic impression, so that we could record that mobile tissue in a stable condition, in a static position. So next, a master cast was obtained, and we went on with the recording the maxillomandibular relationships. So here, teeth was arranged and trine was done. Then there was the acrylization procedure, packing was done, and a denture was delivered to the patient. Whereas in the second case, a patient 65 years, she also came with a complaint of the loose dentures, and she was wearing since 2 years. And we can see here that the flabby ridge was seen in the maxillary anterior region. And for this case, what we did first case was the single impression, whereas this, the primary impression was made as usual, and the custom tray was fabricated for the border molding, and the flabby ridge extension was marked in the patient mouth with a pencil. The same was transferred to the tray. Then a window was created and a light body impression was made. Whereas here only for the flabby ridge, we have injected the light body impression, and then the pickup impression was made. Again, here we can see after the master cast was obtained, occlusal rims done, jaw relations recorded, and then trine was done. Here we can see the dentures, and pre-op and post-denture insertions would be appreciated, how it changed the patient's profile also. And a proper post-insertion instructions were given to the patient to how to maintain the dentures. Coming to the discussion, always the first step in creating an acceptable denture is to make a good impression. So one of the challenges that the dentist faces when fabricating a complete denture is compromised edentulous ridges like resorbed and flat or the flabby ridges. Our treatment option should be changed. So if it's more fibrous, the surgical removal of the fibrous tissue. There are 3 procedures. One is the surgical removal, the other being the implant retained fixed or removable prosthesis, and other can be the conventional prosthodontics. Whereas here, what we did was we changed it to a non-surgical option where prosthodontically only it was managed. So all this will be done to improve the stability and retention. So here, our paper, what we did the case, it was a very simple technique to record the flabby tissue, and mainly it was in the undisplaced state by using the light body impression material. So the advantage was that there was no need for additional chairside time or any extra appointments for the procedure. So to conclude with, what we want to say is, as a prosthodontist, we face so many challenges while fabricating a complete denture, as we see so many compromised ridges. So all treatment cannot be with the conventional dentures. So since although there are so many numerous techniques or approaches we have, whichever is suitable for the operator and for the benefit of the patients, we go with such treatments. And the impression technique what we use is really it was simple, convenient for the clinician, and also it was mainly well tolerated by the patient, and it was time efficient. So these are the references. Thank you.
Yeah, thank you, Dr. Chetna. You can stop sharing your screen now. Dr. Dvaishali Das, do you have any questions for Dr. Chetna?
Yeah. Hi, Dr. Chetna. Very good presentation.
Hello, madam. Thank you, ma'am. Thank you.
Very good presentation. And I just wanted to ask you.
Ma'am, Dr. Chetna, please stop sharing your screen first.
Exit.
Yes,
Exit.
ma'am.
Yeah.
Yes.
Yeah. All good.
Yes, ma'am.
So, in such a case, when you have these flabby tissues, after the
Yes, ma'am.
denture insertion, after the denture delivery, how do you
Yes,
treat the tissues if the patients come back with inflamed tissues? Because however good the impression technique is there with the denture and the tissues, hyperplastic flabby tissue is going to get inflamed. So what do you
Yes,
do
ma'am.
for that?
Ma'am, that's what I mentioned it. After any denture insertion, what the instructions we give plays a very important role. That's what we tell the patient is they have to take out the dentures during the night times, and they shouldn't where it has to be kept in water. Morning they have to clean it and place so that the tissues won't be like under pressure during the night time. So they
No,
have
but
to strictly follow this, madam.
even then, during the day, there could be some irritation. So we are talking about
Yeah,
what
then
if
what
it
we can
happens. Instructions patients may not follow, but what if it happens, the irritability of the tissue?
That's what, ma'am. When then we can go with the tissue conditioners. We use the tissue conditioners. Am I audible, ma'am?
Yeah, you are.
Yeah, we use tissue conditioners in such a cases, and we tell them to remove the dentures. So around 72 hours, the tissue conditioners will be there. Then we can go on with the thing, ma'am. That's why the technique what we use with the impression is we have recorded with a mucostatic, ma'am.
Okay.
In other conventional dentures, it will be mucocompressive, where the tissue can be compressed and it will be rebounding later. So here we have seen to it that it is in the static state. So if at all still it is there, means we will go with the tissue conditioners.
Okay. Thank you.
Thank you, madam. Thank you.
Yeah, Dr. Sumita, do you have any question for Dr. Chetna?
No, I think for prosto, I'll take a pass.
Okay. Dr. Rumpavik, do you have any question for Dr. Chetna here?
No, Sonal. I enjoyed what she presented. And the question asked by Vaishali was very relevant. So she answered that as well. So gives us a boost to do that. Thank you. Yeah.
Great. Next in line, we have
Thank
Dr.
you so much.
Swati Gotmare. Dr. Swati Gotmare, are you there?
Yes, ma'am, I'm there.
Yeah, please start sharing your screen, ma'am.
Yeah, 1 second.
That's a lovely sari you're wearing, Dr. Swati.
Thank you so much. Today is a women's
Swati was last year's winner also for this contest, and she had participated for the faculty contest. This year we don't have any faculty contest, but she wanted to be a part of Pink Dental Congress. So
Yeah,
welcome,
I
Dr.
wanted to
Swati, again.
specifically as this is the especially for the women, so I always like to be to present as a woman.
Yeah. Please start sharing your screen, doctor.
Yeah, I'm starting. 1 second. It's taking little time. 1 second. Sorry for the delay. Yeah, my screen is visible.
Yes, doctor.
Hello?
Just go to
Yeah,
presenters
am
mode
I
or share.
audible? Yeah.
Yeah, you're audible. Yeah, please go ahead. Just share your screen, doctor. Presenters mode.
Presenters mode.
Go on the right lower column, below. You see that 63%. Just come next to it. There's an icon there. Share screen icon.
Yes, I shared it. It is not visible. You share, I have to.
Yeah, you have to share the screen. Or maybe go on the presenters mode. Full screen. Yeah.
Can you see? Can you see it now? Yeah, I already shared the screen
I know
now.
that thereafter you have to go on a presenters mode also.
Okay,
Slideshow, on the slideshow.
on the slideshow.
Dr. Swati, just start your slideshow for your.
Yes, not your slideshow.
Go down. Go down.
Yeah. Is it there? So can I start?
Yes, yes, start, please. Your time starts now, Dr. Swati.
So good afternoon, all the lovely ladies and audience present over here and respected jury members. Happy Women's Day to everyone present over here. The storm of hormones that is induced during pregnancy causes changes in the mother's body, and the oral cavity is no exception. The mouth serves as a mirror to general health status and also acts as a portal for diseases to the rest of the body. Oral health during pregnancy has long been a focus of interest, but it has been ignored by both the patient and the physician. With this, I present you a topic that is the dental conditions in pregnancy. Oral health, which includes the health of the jaw, bones, teeth, and gums, is the mirror for general health and well-being. But in or WHO has mentioned that it has been depicted in the patient as well as the oral health professional and the general health professions. Oral health and the pregnancy. So, what is the dental health and how it affects during pregnancy? As there are so many physiological changes during pregnancy, such as the hormonal changes, altered immune response, there are many changes which reflects in the blood chemistry, cardiovascular system, respiratory system, gastrointestinal, and there are many other changes which are present in the pregnancy. The importance of oral health during pregnancy extend beyond just not with the dental issues, but it has implications for the health and well-being of both the mother and her baby. Expectant mothers should prioritize good oral hygiene, maintain regular dental checkups, and seek professional advice for the oral health issues. So, poor maternal oral health and pregnancy outcomes with the preterm delivery, low birth weight, and high risk of early caries among infants. But in India, pregnant women do not have sufficient knowledge and they are neither aware about the importance of oral health during pregnancy nor infant oral health. Many do not understand that the oral health care is an important component of the healthy pregnancy. A, brief, a belief that poor oral health status during pregnancy is normal and they do not seek or receive oral health care during pregnancy. These are all the changes which we can see during the pregnancy, mainly because of the hormonal changes and morning sickness. There is an increase in the number of microbial flora in the mouth and plaque formation, and that leads to the many of the issues in the oral cavity. But when we have gone through the literature regarding the knowledge, attitude, and practice of the professional on oral health care, not only of the oral professional but the general health profession, we come to know that many do not understand that the oral health care is an important component of the healthy pregnancy. There is a lack of routine assessment of the pregnant woman's oral health status by perinatal care health professional and referrals to the oral health professionals. Also, oral health professionals tends to postpone providing oral health care to the pregnant woman because of the lack of the knowledge during of the pregnant woman changes. So, educating pregnant women about preventing and treating dental conditions is critical. Most young children acquire caries causing bacteria from their mothers, and counseling may reduce the transmission of the bacteria from mother to the young children, thereby delaying or preventing onset of the caries. Common oral conditions during pregnancy are gingivitis, gingival hyperplasia, pyogenic granuloma, melasma, salivary changes. So there are changes in the pregnancy which occurs into the teeth, gums, as well as the oral mucosa and salivary changes. Most common is the melasma. You can see an increase in the pigmentation on the facial skin. Then coming to the dental caries, because of the hormonal changes and uh, because of the acidic environment increase in the oral cavity, there is increase in the oral microflora as well as the increase in plaque formation that leads to the demineralization of the teeth, and that leads to the cellulitis, pain, discomfort, abscess, and that if it is not treated properly at the time, then maybe the loss of the teeth. There are the periodontal diseases in which we can have the from normal marginal gingivitis to the abscess formation or advanced periodontitis, and also that can lead to the tooth loss if it is ignored during the pregnancy or after the pregnancy also. Clinical features of these, I will not go much in detail about this as most of us all are aware about this. Pyogenic granuloma, which normally dentists come across with the pregnant patient. And if all these things get unnoticed and not treated properly, then can lead to the tooth mobility and tooth loss. Also, there are the cases of tooth erosion during pregnancy because of the increase in acidity and reflexes, acid reflexes. Also, there are some changes into the saliva, and because of that, there may be the oral mucositis and the glossitis. So in this chart, you can see the changes which occurs during the pregnancy in first, second, and third trimester. And to avoid all these things, we should have the plaque control on a routine basis. Oral hygiene techniques can be introduced to the patient, specifically to the pregnant woman. Then scaling and root planning, use of non-alcohol based oral rinses, and fluoride to the patient having caries incidence more. Coming to the suitable timings and dental treatment, in the first trimester, avoid x-rays, only emergency treatment can be possible. In second trimester, root scaling, planning, and elective dental treatment. Also avoid x-rays, but if it is necessary, we can do it under proper precautionary measures. Third trimester, avoid treatment in second half of the third trimester. During elective dental treatment, we have to take care of the position of the patient. So, patient should place in a flat position more towards the left side and placing a small pillow under right hip so that there will be a left lateral displacement to avoid the supine hypotension syndrome. While taking the radiograph, please take the proper precautionary measures with lead apron and thyroid collar. But yes, in the first trimester, we have to avoid the dental radiographs. We have to take care of the dental care during pregnancy, and these are the tips for maintaining the oral health during pregnancy. Medications and which we can prescribe during the pregnancy. Yes, local anesthesia we can give it, but analgesics, these are the list of the analgesics and local anesthesia which can be prescribed, and this is the list of the antibiotic administration for the during pregnancy which can be prescribed. We have to avoid the diazepams and barbiturates. Some myths and facts regarding the during pregnancy are: first is dental treatment should be avoided during pregnancy, as we are all aware about that. Yes, we can do the dental treatment with all precautionary measures. Dental treatments can harm the fetus. No, if we have used the proper precautionary measures and proper treatment protocol, there is no harm to the fetus. Pregnancy causes tooth loss. Pregnancy doesn't cause it, but if we have not provided attention towards the dental condition, then yes, after pregnancy also, women, they try to ignore the dental diseases, and then that can lead to the tooth loss. Morning sickness doesn't affect dental health. Yes, morning sickness definitely affect dental health. So that's why during the frequent vomiting, we should prescribe the non-alcohol mouthwashes, and vomiting can be prevented. Dental x-rays should always be avoided. No, dental x-rays can be done if it is necessary with proper precautions. You shouldn't visit the dentist until after pregnancy. Definitely, patient has to visit dentist during their pregnancy. Dental health doesn't affect pregnancy outcome. No, dental health affect the pregnancy outcome. And these are all the risks which are there if the oral health is not proper during the pregnancy. Preeclampsia, preterm or birth or a low birth weight, bacterial transmission, chronic health implications, and psychological and emotional impact to the patient. So, I would like to conclude an effective model of conceptualization, the management of the uh, patients needs dental treatment needs of the pregnant women is needed. Also, studies demonstrated that gynecologists have a relatively high degree of knowledge with respect to the relationship of periodontal disease to pregnancy outcome. However, there clearly exist misconceptions regarding the provision of dental treatment during pregnancy. To provide better oral health care, more knowledge needs to be made available to pregnant women and medical community, and misconceptions regarding the type of the dental treatment during pregnancy should be clarified. Gynecologists plays a vital role in providing primary health care during pregnancy, and they should act as a bridge between the dentist and the patient, so that they should refer the pregnant patients to the dentist for further treatment and precautionary measures. So the take-home message is the oral health promotion, diseases prevention, early detection, and timely intervention are crucial aspects of the maternal and child oral health. It is widely established that many, if not all, routine and preventive dental procedures can be safely performed throughout the period of the pregnancy with certain precautions. Primary care personnel are also in a position to provide a basic oral health counseling. Thank you. These are all my references.
Yeah, thank you, Dr. Swati. And Dr. Rumpavik, do you have a question for Dr. Swati?
Yeah, I do. Hi, Dr. Swati. That was just amazing. Very nice. And the few tips which you shared. My question to you is you advocated fluoride varnish to the pregnant ladies. So, my question is related to what is the concentration you would like to advise and what is the duration of time? And do you have any commercial brands which you normally prefer for usage?
No, I'm not aware about the commercial brand, but yes, with fluorides, you can be given to the patient fluoride varnishes with a low concentration.
Low concentration. And what is the duration, ma'am?
Duration,
Means for how much time should I advocate? Suppose a pregnant girl comes to me, so, and I see that she is prone to caries. So, for how long should I prescribe the fluoride varnish to her? Simple question, that's it.
yeah, I've not fluoride varnishes duration. You can prescribe it in the second trimester.
And for how many days, ma'am?
No,
Like how many times do I have to call the patient? How many sessions, if I can make my question more clear?
session generally for fluoride varnishes, we have to call them like thrice.
Okay, okay, ma'am. Thank you.
Okay, ma'am. Dr. Vaishali Das, do you have any question for Dr. Swati?
No. Thank you, Dr. Swati, and Dr. Rumpa has already clarified whatever was there in my mind. So,
What about Dr.
Um,
Sumita? Do you have any questions?
No, beautiful presentation. I'll take a pass for the question. Thank you.
Okay.
My main concern was to get the attention that these areas for the pregnant women are ignored. And as there is a even the pregnant women also, they don't pay attention toward their oral health as it is. So that's why there should be some policy which can be done by the oral health professions as well as the uh, gynecologists, that there should be some policy for the taking care of the pregnant women oral health.
here
Yeah.
I would just like to add one point. Maybe
Yes.
in Mumbai or any metropolitan city, we can still implement all this. This paper is more relevant in the rural areas. Matlab, I feel someone should take care of that in those regions where they actually need it.
Yeah, there is a need of awareness.
I guess we need to make the gynecologist aware that this is important.
No,
Yes.
if I might add my two bits, maybe when young girls are taught about menstrual health in schools, at that point of time, just one point is made that whenever you plan to have a baby, or when you get married and you feel that you might have a baby, then you should, stress on oral health and have a checkup and eliminate any major problems before you conceive. So that might be a very good thing because I have seen that in all the metros and in many of my friends abroad, and people are very particular about having a stable oral hygiene before they plan their child. Maybe something like that can happen in our country in the future.
Yes, days are not far. So
Definitely.
awareness creation is in our hand as a oral practitioner, oral health practitioner. We can do that. So yeah, it's a nice point that it should be included into the school's curriculum also. That's a very nice point. Okay, so should we begin with the next speaker, or you all want a break? Okay, so next we have in line Dr. Dipanshi. Are you there? Yeah, Dr. Dipanshi, are you there?
Uh, yes, ma'am. Good evening, ma'am.
Good evening, doctor. Yeah. So, are you from? Yeah, you're a faculty, right?
Ma'am, I'm a general dentist. I practice in a clinic. I'm an associate dentist.
Okay, fine. So start sharing your screen and all the best, Dipanshi.
Thank you, ma'am.
Dr. Dipanshi's paper is a contest paper?
Yes, ma'am. It is a literature review.
No, ma'am,
No.
it is not a contest paper.
Okay.
I will let you all know when the students start so that in that one go we will go with the students ahead. Let them join
Yeah.
first because everybody is joining from the college. So they are just returning or they are in the commute still. So we'll wait for them. Okay. Let the faculty get over with.
Very good evening to all the beautiful women present here.
Yes, Dr. Dipanshi, go ahead, please. Good evening.
Okay. I am Dr. Dipanshi from Patiala, Punjab, and today I am giving a paper presentation on menopause and oral health. Basically, it is a literature review. Menopause and oral health, unlocking the hidden impact of menopause. So, the World Health Organization defines menopause as the last menstrual bleeding, which usually occurs between the ages of 45 and 55. And like all the various phases that a woman goes through in a lifetime, menopause is also accompanied by a number of hormonal changes. And a dentist is the first person to encounter these changes going throughout her body during menopause. And the hormonal deficiency, which I am addressing today, is estrogen deficiency. Now, estrogen, it is known that the literature, as per literature, the oral mucosa has a number of estrogen receptors present all over there. So, estrogen deficiency causes a direct effect on the oral cavity, beginning with the maturation of the oral epithelium is disturbed when the serum estrogen levels are decreased. As we all know that salivary glands are also hormone dependent, the concentration and the amount of the salivary secretion is also altered due to estrogen deficiency. As the consequence of this decreased salivary secretion, the effect is also there on the periodontal health of the tooth. So the periodontitis is also caused due to estrogen deficiency. Now, taking a look at the disturbed maturation of the oral mucosa, the oral mucosa is not mature, is not mature, it becomes very atrophied and thinned. This causes a causes defective mechanical properties of the oral mucosa. Now, there are increased mechanical injuries that are also caused due to removable prostheses are increased in the number due to this disturbance. An increased susceptibility to autoimmune diseases like pemphigus, lichen planus can also be seen during this specific period of the women's life. And one of the most important thing that I would like to address today is the patients of the postmenopausal women patients, when they come to a clinic, we all have encountered them suffering from symptoms like burning mouth syndrome. Now, burning mouth syndrome is a chronic condition that is characterized by a burning sensation of oral mucosa, which is usually or almost always accompanied by xerostomia, that is oral dryness, but there is no identifiable any clinical lesion present in the oral cavity. There's a uh, the patient complains of pain, and this pain is usually localized in the tongue, and the pain is accompanied by oral dryness, hypersensitivity to certain kind of foods, and swallowing difficulties. Gao et al. Presented a study in 2019 stating that the patients who were going through a burning mouth syndrome, our symptoms similar to burning mouth syndrome in their menopause, had lower estrogen levels and higher follicle stimulating hormone levels in their blood. Salivary glands, as discussed before, are affected due to their hormone dependency. The amount and the concentration. This is worth noting here that both the amount and the concentration of the saliva is altered during menopause. There is decreased salivary flow rate, there is increased serum inorganic calcium, and there's a reduced concentration of the salivary lysozyme, which is known to be antibacterial, antiviral, and antifungal. Now, these all come together and cause xerostomia or the oral uh, dryness, and increased oral infections, increased mineralization of plaque. Now, the second most common clinical presentation in menopause due to this lowered serum estrogen level is xerostomia or dry mouth during menopause. It is a very subjective oral dryness. It can change from patient to patient, and this is one of the common symptoms that we have all seen in the OPDs. This is due to decreased estrogen levels in the menopause, and studies have shown that patients on hormone replacement therapy or patients taking estrogen orally or through other routes of administration were relatively relieved from these kinds of symptoms. Now, periodontitis is an inflammatory disease, and the effect of periodontitis is severe and most often seen in women during their menopause. Due to the lower estrogen levels, estrogen deficiency, there is changes in the inflammatory mediators, changes in the vascular permeability, which leads to differentiation of fibroblasts being altered. This leads to periodontitis. And on the other hand, there's a faster mineralization of the plaque, leading to increased calculus formation that we all know also leads to periodontitis. And due to a large variety of complaints and symptoms that are occurring in the oral cavity during menopausal symptom, they constitute a significant group of patients that need to be taken special care of. Usually during menopause, the ages between 45 and 55, women tend to ignore themselves. Moreover, if we see in the clinical practice, the women of this age, healthcare providers sometimes also neglect that the symptoms that a women is facing are actually due to menopause or lower serum estrogen levels. So first, let's take a look on the prophylactic recommendations. Prior oral examination and intricate oral examination, detailed history taking is very important before the beginning of menopause or the perimenopause phase of the women. Special assessment of oral mucosa in terms of hydration, avoiding alcohol-based mouthwashes, avoiding toothpaste that have sodium lauryl sulfates, which ultimately lead to a further more dryness or xerostomia. Then extra oral hygiene care should be taken care of, because they will obviously lead to more caries and periodontitis. Now, the emerging treatment recommendation that is a newer thing that has been arrived is hormone replaced therapy, which was obviously used for the systemic purposes before also. But for the oral symptoms, hormone replacement therapy has been extensively used to alleviate the menopausal related symptoms due to estrogen deficiency. Various studies have been performed, various literature reviews have been given, which clearly depict that hormone replacement therapy is emerging as a new treatment option. In 1999, Wolf et al. Observed that hormone replacement therapy improved the subjective and objective symptoms in more than 50% of the patients. Oral hydration symptoms were reduced after the hormone replacement therapy, and the mean salivary estrogen levels were also increased. The most common symptoms, there are two most common symptoms that are experienced by women in the menopausal phase are oral dryness, that is xerostomia, and burning sensation. And these both two symptoms have been seen through studies and seen through clinical practice, have been resolved by the hormone replacement therapy, or specifically the menopausal hormone therapy. So I would like to conclude that menopause profoundly has impacted oral health, presenting various challenges like xerostomia, burning mouth syndrome, gingivitis, periodontitis, and hormone replacement therapy is emerging as a potential intervention for these conditions. It is ever presenting in various routes of administration, in various dosages, in various formulations that hormones are given, and the symptoms of the oral symptoms that are caused by the menopause and the estrogen deficiency are relieved. Thank you so much.
Yeah, thank you, Dr. Dipanshi. And I would like the jury, Dr. Sumita, to ask any question if she would like to ask Dr. Dipanshi.
So, it's a very beautiful review paper. Doctor, what I would like
Thank you.
is in your clinical practice, what is the most common symptom that you have seen with menopausal women?
Okay,
And
ma'am.
in your practice, you must have that age group of women also.
Yes, ma'am. So recently, last week, a female patient, she presented at a clinic, and the symptom that she was presenting was even that she was eating mild spicy foods. She had burning sensation in her tongue, in the buccal mucosa. That was the she was very concerned about it. Uh, she has done a lot of home remedies. Like, this is the first thing that all the women in our country, they go for it. So she was trying various home remedies. Then what we came to understand, that it was actually due to the phase that she was in. It was actually due to the age she was growing through, the hormonal changes that she was growing through. So we presented both prophylactic and therapeutic measures, which was the first line of the treatment. We have recalled her after 1 month, that if these symptoms resolve, then it's well and good. If they don't, we should definitely refer to a gynecologist, and we should start with the hormone replacement therapy, because there is a certain kind of stigma related to the specifically hormone replacement therapy, which I understand, because it's a newer thing, it is a newer advancement, it is not so easy to accept for everybody. So this is how we manage the patient.
Nice. Thank you.
Thank you, ma'am.
Dr. Vaishali, would you like to ask any question?
Yeah, just a little maybe extension of what Dr. Sumita has asked. Like, didn't you try any local measures like what we do in any mucositis patient?
Yes, ma'am.
May not necessarily uh, menopausal woman, or for patients undergoing radiation as well. Local measures,
Yes, ma'am.
mouthwashes,
Yes, ma'am.
like wet mouth. Didn't you try anything like that? Because I honestly feel HRT is a little more invasive when you go systemic with that.
Yes, ma'am.
So, I mean, I'm just adding my bit of knowledge to this thing, that I first always try with the oral and local thing.
Yes, ma'am. That was the
because systemic will work all over the body.
all of the body. Yes, ma'am. That was the first line of the treatment. We give
What did you do?
first thing first, we asked her to cut down on the citrus foods, that are acidic fruits and foods. Secondly, we gave her toothpaste that was free of SLS, sodium lauryl sulfate. Thirdly, we gave her a local anesthetic gel. Then we gave her so, something that helped. We gave her a vitamin supplement, vitamin B complex supplements, and zincovit, so that the oral mucosa is secured for the time the healing period that she will go
Right.
through.
Next time you can just add wet mouth
Rinses.
wash to it.
Rinse.
That will
Yes,
help the
ma'am.
patient big time.
Yes, ma'am.
Thank
Thank
you.
you, ma'am.
Lovely
Thank you.
presentation.
Dr.
Thank you,
Rumpa,
ma'am.
any question for her?
Yeah, hi. Actually, my question completely concurred with what Vaishali asked. So nothing new, but yes, I would like to know, do you give the the lidocaine or
Yes,
the
ma'am.
gel which you are giving? Do you give it out to the patient to apply at her own free will, or do you prescribe it and call her back to your clinic?
Ma'am, we prescribe her. We don't tell her to use it as much as she wants.
Okay.
We tell her to use maybe twice a day or thrice a day, according to the pain or the condition that she's suffering through, or the what requirement she is in. We recalled her. We recalled her that if you think that we definitely recalled her.
Okay. Thank you. Thank you.
Thank you. Thank you, ma'am.
Yeah, and very beautiful
For my
presentation.
knowledge, I'm sorry. This is for my knowledge, Dr. Dipanshu. Did she also have vaginal dryness, the patient?
Yes, ma'am. That patient didn't have
Never
vaginal
mind.
dryness.
It's okay. Thank you.
Okay.
Yeah, I know from where you're coming from, Dr. Vaishali, and that triad you're looking out for the mucosal dryness and all. Yeah, so it all sums up to one thing. It's body we are talking about. So we need to be thorough with our systemic factors also that influence the
Yeah,
whole.
because HRT will help when the vaginal dryness is also a part of it. So that time HRT becomes mandatory.
Yes. Okay. Thank you, Dr. Dipanshi.
Thank you, ma'am. Thank you, ma'am.
Yeah. So next we have Dr. Afia and team, and Dr. Nihal Mariam is going to be presenting. Is the team present?
Yes, ma'am.
Yeah. So here we have a unique combination of three speakers, and I think one of them is going to be presenting. First of its kind paper presentation, I would say. So all the best, and you may start sharing your screen, Doctor.
Yes, ma'am. Sure, ma'am. So, good evening, everyone.
Please go on slide share mode, madam.
Yes, 1 minute, ma'am. Good evening, everyone. Today, my paper presentation is on apical barrier technique for management of endodontic retreatment with open apex cases. That is, I'll be presenting two case reports here. So the primary etiological factors for open apices is usually the traumatic injury to the tooth, which might lead to the loss of vitality of pulp and arrest the root development. This causes pulpal necrosis. So there comes a challenge in treating the open apex cases because it's very difficult to have there's an absence of natural apical construction in an young permanent tooth, which makes the endodontic treatment a very challenging. Coming to the endodontic triad, so it's very important we do the proper cleaning, shaping, and obturation of the canal. If not, it might lead to the endodontic failure. And there have been studies which showed that endodontic failure was mainly because of the E. faecalis. That is about 24 to 77% of the cases were due to E. faecalis, and also other organisms such as Streptococcus also led to the failure of the endodontic treatment. then it might be also because of the improper obturation. There might be over obturation or under obturation, which might lead to the failure of the endodontic treatment. So hence the goal of the endodontic treatment is to eliminate completely the microorganisms of the root filled teeth, and also to provide proper apical as well as the coronal seal. Coming to the various
Dr.
treatment.
Afia, very sorry to disturb you again in between, but can you switch on your screen camera, please?
Yes,
I'm not able to see you in person.
Oh, sorry, ma'am. Mm.
Okay, forget it. If it's a difficulty, continue with your presentation. Don't go back.
So the
Don't go
way,
Continue.
various treatment options which have been seen to treat open apex cases are apexogenesis in case of the vital teeth and apexification in case of non-vital teeth. And there are various treatment modalities in apexification that could be in earlier days, rolled cone technique was done. Nowadays, we have a periapical surgery, short field technique, and the most important one is the apical barrier technique, wherein earlier it was calcium hydroxide which was used. Nowadays, we have MTA and biodentine, which is used as an apical matrix. So, in this present paper, I'll be highlighting the non-surgical management of a symptomatic central incisor as well as a premolar with the improperly treated root canal and open apex using a biodentine or the MTA in combination with the PRF as an internal matrix. Coming to my first case, here we can see that patient reported with a complaint of pain with respect to 2-1, and he gives a history of root canal treatment done 5 years ago. So when the radiograph was taken, we could see that improperly obturated tooth, and there was a lesion. So the treatment was begun, wherein first initially we instrumented the canal. Minimal instrumentation was carried out because we could see that it was an open apex case. All the remaining obturating material was removed, and then intracanal medicament, that is calcium hydroxide, was given in this case, where a temporary restoration was given, and patient was recalled after 2 weeks. Later, PRF was placed as an internal matrix against which the MTA was restored up to 4 millimeters of the canal. Then it was completely obturated with the thermoplast size obturation technique. Here we can see the post-obturation radiograph as well as the follow-up radiograph, wherein we can see healing of the lesion. Coming to my second case, here patient reported with a pain in the lower right back tooth region. When the radiograph was taken, it was seen that over-obturating material, gutta was seen, and there was also a lesion. So the canal was, the access opening was done, and the obturating material was removed and re-instrumented. Similarly, then here in this case, triple antibiotic paste, that is minocycline, tetracycline, and was used as a intracanal dressing for 2 weeks. Then the patient was recalled, and later on we used PRF followed by biodentine in this case, and then it was obturated with a thermoplast size obturation. And we can see the follow-up radiograph which shows the healing of the lesion. Coming to platelet-rich fibrin or PRF, it is basically collected, and then it was centrifuged for 10 minutes, wherein the middle portion of the centrifuge blood was collected and it was used. So coming to the discussion, a successful management of a failed endodontically treated immature permanent tooth with periapical lesion was observed in both the cases. According to Chokran et al., an apical barrier technique will support the obturating material to confine within the root canal system. That is, it will prevent any obturating material from extruding from the canal, as there is an open apex. So apexification will not a previous endodontic procedure could have damaged stem cells from the apical papilla. According to Madhubala et al., they reported a reduction of up to 95.4% of colony when triple antibiotic paste was used. But when calcium hydroxide was used as an intracanal medicament, only 59.4% was reported. Also, we know that in case of retreatment, it is mainly due to the E. faecalis, and also other microorganisms could lead to the failure of the endodontic treatment. So it's important to have a proper cleaning and shaping of the canal, along with which we can do canal sterilization with the help of a diode laser. So the present case reported was associated with a secondary infection. Hence, triple antibiotic paste was chosen as an intracanal medicament. Coming to the advantage of MTA, advantage of biodentin over MTA, we could see that in second case we used biodentin, wherein there was the advantage was that it had decreased secting time, and also we could do this procedure in a single appointment. That is, permanent filling we could give in the same visit, and also a biodentin showed a lesser micro leakage when compared to that of the MTA. Now, why apical matrix is needed? To avoid any extrusion of the obturating material. Also, there might be a sealing, a micro leakage of the sealing material, which might cause the periodontal damage to the tissues. This PRF, which was used as an internal matrix against MTA and biodentin, would be placed as an apical barrier, which would result in a rapid angiogenesis, and this will further result in an easier remodeling of the fibrin. Thus, it releases various growth factors such as platelet-derived growth factors, and also transforming growth factors, with resultant optimum healing of the lesion. Also, here we used a modern obturation technique, that is thermoplasticized gutta percha, which was seen to have a long-term success in dealing with irregular and larger canals. A longer follow-up of cases is necessary to ensure success of the endodontic treatment. This procedure is predictable and less time-consuming, with a high overall success rate and a good patient compliance. To conclude, a combination of a proper case selection and a stringent disinfection with the help of an endoactivator or a canal disinfection with a diode laser protocol, and a precise and a controlled placement of an apical barrier, that is the placement of a PRF membrane followed by MTA or biodentin, is necessary, which will lead to better periapical healing with the help of a non-surgical apexification procedure. So we can conclude by saying that the barrier technique using the biodentin along with the PRF matrix as a dentin substitute while treating cases with open apexes has been shown to shown a higher success rate. Thank you.
Yeah, very good presentation, doctor. And now I hope I can see you online. So
Yes,
with
ma'am, sure, ma'am.
your camera and stop sharing your screen. Dr. Sumita, I will leave the questions to you first, because this is your forum and this is your forte. Yeah, now we can see you also, doctor. So Dr. Sumita, any questions?
Yeah, so I wanted to know the age of both your patients.
So the one patient was 18 years, ma'am. Yeah, other patient was around 21 years.
Okay. So in both the cases, I observed that the remaining dentine thickness was very less.
Yes, ma'am. Since it is an open apex cases, there has not been root dentin formation, complete dentin formation.
Yeah, I understand that. So, since probably the trauma has occurred at a very young age, so even the remaining dentine thickness hasn't proceeded to its optimal thickness.
Yes, yes.
So, in this scenario, what special measures did you take to prevent further reduction of the dentine thickness?
So,
Cleaning and shaping, what happens is that there is definitely some degree of dentine loss. So how did you prevent that?
So like here we have done minimum instrumentation. Mainly we focused on cleaning of the canal, that is by using endoactivator in case of the first case, and canal disinfection or canal lesion sterilization was done using diode laser. So we ensured that there is a minimum amount of shaping of the canal where where we did less of instrumentation and more of cleaning.
So what was your preferred instrument?
Preferred instrument here we used initially, even the hand file which was used, ma'am, it was looser. The 80 number hand file which was used, it was loose in the canal. So we instrumented up to 80 number hand file, and then we went for this one endo activator was used, and in the second case diode laser was used.
So that's actually the point that I was wanting to stress on, that in the management of such, your simple 2% hand files are more than sufficient. As long as you have the concept very clear that you do not want to sacrifice dentine,
Yes.
but at the same time you want to sterilize the canal. It's very well managed cases, both.
Thank you, ma'am.
Dr. Vaishali, do you have any question? You unmute yourself, doctor. Dr. Rumpa, are you there?
Yep, I'm there.
Yeah, ma'am. So any questions for...
I'll take a pass because I'm a Lady Shakespeare in endo. So I just know the basics. I do not do endo at all. So Subhita, she has handled it so well. Absolutely.
Yeah, when she
But
says
a
the case
very
is
nice
done,
presentation. I loved it.
yeah, when she says the case is done well, 100 marks to the presenter then. Okay, Dr. Vaishali, can you unmute and ask the question? Ma'am, I can see your lips moving, but... Okay, fine. So I think there is some issue with her. Okay, we'll give her one more minute.
I think her issue is helping her.
Yeah, Dr. Ratin Das, hello, sir.
Hi everyone.
Yeah, you no, she's blurred you, sir. So as
Wait,
usual,
no, but
she's
you
the
could guess, no?
yes.
Hi
she's the
Rumpa, hi Didi, how are you?
Hey, bye.
Camera
Good
on.
to see you. All good.
You're live on YouTube.
Chalo, chalo.
Dr. Das, you have any question for her?
No, actually, like whoever Potter was there, I handled it very well. So we give it a pass.
Okay, now we have our next speaker, Dr. Ashmit Kaur, and a different take on dentistry. And I'm very delighted to call her on stage. So, Dr. Ashmit Kaur, are you there?
Yes, ma'am.
Okay, doctor. All the best, doctor. Start first. Switch on the camera. Whoever are the speakers, we would
Sure.
like to see you all. We are hungry to see good
Hello,
faces,
ma'am.
beautiful faces around here. So please share your screen, doctor.
Sure.
Everyone,
Hi.
happy Women's Day to everyone.
Thank you, doctor. Thank you so much.
Ma'am, is the screen visible?
Yeah, in between I could see your screen, but now not visible. Yeah, now it is visible. Go on a share
Sure.
screen. Yeah, perfect, doctor. Continue.
Sure. Good evening to everybody present. My topic for the presentation
Dr.
today
Kaur,
is...
excuse
Yes,
me, there
ma'am.
is echo that is going on. Maybe there is one more screen in parallel. Or anybody is unmuted themselves, please mute you all your screens, please mute. Is there any parallel screen going on around with you?
No,
Okay,
ma'am.
there is some amount of echo.
Sure. Should I continue, ma'am?
Yeah, your time starts now, doctor.
Sure. So my topic for the presentation today is the therapeutic uses of botulinum neurotoxin, commonly called as Botox. So these are going to be the contents of my presentation, which is introduction, the basic mechanism and basic structure of a botulinum toxin, the clinical applications, toxin immunogenicity, the contraindications, as well as the side effects and the precautions required. Coming down to the basic introduction, it basically involves that botulinum toxin as a protease exotoxin, which is produced by a gram-positive rod-shaped spore-forming bacterium called as a Clostridium botulinum, which is basically an anaerobic bacterium. When released, it causes the inactivity of muscles or glands by blocking the acetylcholine activity while they're trying to act on the receptors. There are several different basic serotypes that are based on their antigenic properties. This picture just gives us an idea regarding the structure of the Clostridium bacterium. Coming to the history of botulinum toxin, the introduction of botulinum toxin happened in the early of the 19th century. It started being endorsed as a bioweapon. Here we can also see that the World War II, where the Japanese invaders started using it as a bioweapon, which was later followed on by Germany, US, and the USSR. Coming down to the therapeutic uses of the botulinum neurotoxin in the medical field, it began in the late of the 19th century. The first use was advertised by Scott in the year 1977, which was used to treat the cross-eye. The United States FDA Association basically approved the botulinum toxin A to treat cross-eye, blepharospasm, and the hemifacial spasm in the year 1989. Coming down to the basic structure and mechanism, structurally, the botulinum consists of three main domains, which is a light chain, heavy chain, and then is basically divided into an internal translocation domain and a C-terminal receptor binding domain. The figure here is that of the botulinum toxin, which is basically like a ribbon-formed structure. Physiologically, acetylcholine is released from the cytosol, which is present at the neuromuscular junction at the synaptic cleft. The acetylcholine is released through a transport protein chain, which is called as the SNAR, which basically includes the VAMP, which is the vascular metalloprotein phase, along with the SNAP25 and the synaptin. So what happens basically is, with the introduction of the botulinum toxin in play, it basically prevents the binding of the acetylcholine once it is released from the cleft into the receptor sites that are present. So this blocking basically prevents the muscle contraction, which is one of the basic reasons why there is so much of cosmetic use of the botulinum toxin, but which is not the primary case of discussion here. So the clinical applications are just narrowing down to the basic therapeutic uses. Bruxism, it is a repeated oromandibular activity which is characterized by the clenching and the grinding of teeth that can result in basically a sleep state as well as an awake state. It results in muscle pain, TMJ pain, tooth wear, and also brings about a lot of damages to the dental prosthesis. According to the review, the link of which has been shared below, it reduces the frequency of bruxism when compared with the traditional methods. The traditional methods basically are the appliance therapies and the behavioral therapies. So botulinum toxin adds as a great adjunct to the entire therapies that are required for bruxism. Massive-trick hypertrophies basically comes in synchronous with the bruxism as a concept, but again, there is unilateral and bilateral enlargement of the masseter muscle that can result in bulky jaws and causes an including chronic clenching, habitual asymmetric chewing, TMJ dysfunction, and congenital factors. It's an asymptomatic condition that the patients experience dissatisfaction due to its aesthetic appearance due to the bulking of the masseter muscle. So here in the diagram, we can see that there is a specific landmark that has been mentioned for the insertion of the botulinum toxin injection along the masseter muscle in order to reduce the hyperactivity as well as to reduce the size of the masseter muscle. Another great indication would be a TMJ dislocation when it happens when the condyle moves forward from its functional position within the glenoid fossa. It causes stretching of the muscles and ligaments, which leads to pain in the orofacial region. It can occur either as an acute or a recurrent event. So the basic use of Botox comes into play when it basically happens in a form of a recurrent event. Usually in an acute case, what we as oro and maxillofacial surgeons try and do is a manual manipulation. But in recurrent phases where there is excessive pain and it just becomes very difficult for the patient, so botulinum toxin therapy does come into play as an adjunct when it comes to TMJ dislocation. Myofascial pain, it is characterized by acute or chronic regional muscle pain with a single or even several circumscribed painful sites, as have been shown on the masseter as well as the temporal muscle. Again, the treatment is usually multidirectional. There is pharmacological management with the help of the non-steroidal drug therapies. Again, botulinum toxin injections, they help to alleviate pain by suppressing muscular contractions and preventing the release of acetylcholine at the site of these trigger sites. Hemifacial spasm, it is a chronic condition of the nervous system that causes involuntary twitching of the muscles on one side of the face. There might be an artery that contacts or a pulsation that might be seen along the facial nerve, which is the most common cause of hemifacial spasm. Currently, botulinum toxin is widely considered as a treatment of choice for managing the hemifacial spasms, as it basically suppresses the release of neurotransmitters and causes neuroparalysis. Whenever there is any sort of a botulinum toxin injection that is planned for a patient with a hemifacial spasm, it is mandatory that the guidance should be done with the help of electromyography in order to prevent any sort of accidents that might come about. The muscles that are mentioned in the diagram are the specific muscles, the major muscles, which is the orbicularis oculi, zygomaticus major, minor, and the risorius, which are basically involved in the hemifacial spasm. The orofacial dystonia, dystonia as a basic disorder can be described as an involuntary muscular contraction that leads to rhythmic, repetitive, and atypical movements in the orofacial region. Specific to orofacial region, this basically affects the masticatory muscles, which are the lateral and the medial pterygoids, and the masseter and the temporalis. So botulinum toxin injections have also been proven to be promising for managing the dystonia. The superior effects, again, similar to the previous case, that it involves electromyographic guidance for accurate injections of the botulinum toxin at the site of pain. Coming down to facial paralysis, it is characterized by an inability to move the muscles of the face. It is usually affected along one side of the face, and it rarely affects both sides of the face. Also can be caused by trauma, tumors, or Bell's palsy. So there are different grading systems that come into play whenever you're trying to grade the facial paralysis. Again, the introduction of it was done in the year 1987. The mechanism of action of botulinum toxin involves the inhibition of the neurotransmitter release, which aids in relaxing the stiff muscles. So there is a better prognosis, which has been repeated whenever there is a combination therapy and not just botulinum toxin as an isolated therapy when it comes to facial paralysis. So there are specific units of Botox that need to be given considering the muscles that are involved and the muscles that need to be avoided whenever there is any site that is specifically affected. In complex cases, again, surgical management has to be followed up by botulinum toxin administration, as the supplement has been proven to be a better mode than just a monotherapy, as is the case in most of the disorders. Coming down to chronic migraine, it is characterized by severe headache for 15 days per month for more than 3 months, extremely painful for the patient and extremely uncomfortable, that affects the quality of life of the individual as well. In order to treat migraine, there was an initial discussion that happened whenever the patients got the injections, they felt an improvement in the headaches. So this led to several clinical trials investigating the use of botulinum neurotoxin in treating chronic migraine, which was approved in the year 2010 by the FDA again. It is beneficial in migraine management as it prevents the release of the neurotransmitters and the substance P, and it aids in preventing the transmission of pain signals to the nerve terminals as well. Again, the most commonly seen in the oral surgery department, which is the trigeminal neuralgia. It is a neuropathic condition that causes intense episodic pain in the orofacial region, including the forehead, eyes, nose, lips, and jaw. It occurs suddenly with intense stabbing pain and usually affects one side of the face. So the usual management that comes into play are the anticoagulants, the carbamazepine, oxycarbamazepine, the surgical intervention, and the microvascular decompression. In the year 2002, botulinum toxin was introduced for its effectiveness in treating trigeminal neuralgia. The mechanism of action is again thought to involve the inhibition of the neurotransmitter release, which is the acetylcholine, which results in reduced peripheral and central sensitization. Siluria, which is excessive salivation, commonly referred to as paralysis also. It usually affects children and adults with neurological impairments such as cerebral palsy and intellectual disability. It can be idiopathic or drug-induced. The botulinum toxin injection is usually given into the major salivary glands, which is the parotid or the submandibular, and it has been proven time and again that it does help in temporarily preventing drooling. But again, it's not the definitive solution for it. Needs to be followed up with the surgical management as well later on. Coming to the phase Fraze syndrome, which is the auricular temporal nerve association. So this basically causes gustatory sweating, flushing, and warmth in the preauricular and the temporal area. It is a complication of frequent parodectomy, trauma due to incision and drainage of a parotid abscess, or the removal of the submandibular gland. So it's basically a post-operative complication that might come into. So botulinum toxin acts by forming a synapse between the parotid and the sweat glands, thereby preventing the acetylcholine release, hence avoiding the pain and the sweating that comes with it. So preparation and application techniques, basically there are a lot of different trade names in the form of Botox and Dysport. So botulinum toxin injection is routinely administered using a fine gauge needle, which is 27 to 16 gauge. As an adjunct, some physicians do refer to use an electromyographic guidance just to administer the botulinum toxin at the right site, at the right muscle, so as to avoid any sort of complications later on and to just accurately hit the muscle target. As repeated injections are required, the lowest effective dose should be administered initially and at well-spaced intervals to reduce the risk of antibody development, activity, or hyperfunction. There is toxin immunogenicity as well, which is basically botulinum toxin is a foreign substance by the host and it has the potential to induce an immune response. This may lead to successful treatment failures in cases of repeated administration. So it is always advised that any doctors who are going ahead with the process should perform repeated injections over prolonged intervals with the minimum doses possible for a better result. Contraindications, any sort of allergic or hypersensitivity history to the botulinum toxin, any infection at the site of injection in cases of pregnancy and lactation should be avoided, any psychological illness that has been reported in the patient, any use of medications such as the calcium channel blockers, any sort of hypertensive agents that have been used, any sort of drugs that are known to interfere with the neuromuscular impulse transmission, as well as should not be used in cases of neuromuscular disorders. Again, because they might actually worsen the existing state of the compromised neuromuscular transmission. Any side effects of botulinum toxin, it may cause allergic reactions, which can again be prevented by identifying any sort of previous allergic reactions to any sort of brands or constituents of botulinum neurotoxin. Allergy, usually beyond 24 hours, can be managed by oral medications such as antihistamines, and any sort of anaphylactic reactions really should be taken care of like an emergency situation, whether it's just being taken to the ER room and to be reported back to the concerned doctor as well. Any other sort of serious adverse effects are, which is muscular weakness, dysphonia, dysphagia, headache, dizziness, and even respiratory arrest. Severe botulism with the respiratory failure requires ventilator support and tracheal intubation. Close monitoring of the vital signs is essential, and administration of the botulinum antitoxin serum has proven efficacy in such cases. Precautions that need to be taken. The doctor should be aware of the previous history of botulinum neurotoxin injections, the patient's general medical history, drug history, any sort of drug allergies that the patient might have. The patient should not be advised to massage or rub the injection site for a time period of 24 hours, as it may interfere with the spread of toxin to the neighboring sites as well. The patient should be instructed to avoid further skin treatment, and they should also be advised to avoid alcohol intake before and after the botulinum toxin, at least for a time period of 24 hours. So implications are for future clinical practice and research. So there is a lot that can be done with the Botox, considering that it is always in the right hands. There is a lack of data when it comes from in the form of research or randomized controlled trials, but furthermore, several large-scale studies involving large populations are required to confirm the benefits of botulinum toxin in dental therapies as well. There should be specifically designed drug trials as well, which state the guidelines for results that are confirmatory, and further studies should also document the outcomes, quality of life, long-term effects, types and dosage of botulinum toxin to be used, the side effects, and as well as the follow-up. So this is coming down to the summary of the presentation. Botulinum neurotoxin is a promising therapeutic toxin for a multitude of orofacial applications. In the present review, provided detail and update overview of the current available clinical applications. It is a safe treatment that should be used effectively, provided that any doctor or clinician that has adequate knowledge, has the adequate skills regarding the mechanism, the injection techniques, local and systemic side effects that might come into your clinical practice, and having the ability to tackle it all and just take care of your patients carefully and successfully. So these were my references. Thank you.
Yeah, thank you, Dr. Rashmit, and lovely presentation. And this is something which is the talk of the newest generations of dentists are talking about botulinum toxin a lot. Dr. Vaishali Das, I'm sure you have many questions for her, so please go ahead.
Yeah. Dr. Kaur,
Good evening, ma'am.
presentation. Good evening. Excellent presentation. And
Thank you, ma'am.
you have covered almost everything. I don't have much to ask you. Otherwise, it will sound like a viva. But I just want to know one thing from you is for a case of bruxism, when you are
Yes, ma'am.
injecting botulinum toxin, what is the duration? Like, in how many months interval do you inject? Second, are you also doing some psychological therapy for the patient? Because bruxism is not it is a very multi faceted thing. One thing is not going to help you. So if you don't treat the patient psychologically, counseling or whatever stress factor, I don't know how it will help.
Sure, ma'am. Ma'am, when it just comes to specifically bruxism, so bruxism is multifactorial, as you have stated. So what usually happens is whenever we see the patient in the OPD, there are 2-3 departments that we have to inform it about when it comes to orthodontics as a department, because we need to make sure that the night guards come into their daily routine as well. This is not something, botulinum toxin, we don't advise it for young people. We don't advise it for people who have episodes of bruxism as an acute form. So also just looking at the clinical facets, when we're looking at the incisor, we're looking at the facets, how old, how the previous history has been. So we try and tackle in that also. And or with this also, we do have a lot of psychological therapists that are there. There are a lot of public health people that we have in our departments as well, who have a great insight into it, which just helps with the guidance all through along. And probably just adults, probably age that is more than 30-35, that's the ideal target that we have. But patients who are below 30, maybe probably above 25, this is something that we do see in cases of extreme pain and extreme discomfort if they're facing that.
Good. But this is good for a I mean, what you are talking is good for a college where you have everyone handy. In
Correct,
clinical
ma'am.
practice, it is definitely difficult because you have to keep referring the patient to the various people or calling in consultants. But overall,
Yes,
a
ma'am.
very good presentation. You have covered almost everything.
Thank you so much, ma'am.
Dr. Sumita, do you have any question for Dr. Kashmit?
I don't have any questions, but I do want to thank her because my knowledge has expanded considerably after attending this. So thank you, and very nice presentation.
Thank you so much, ma'am.
Dr. Rumpa, do you have any questions for her?
Actually, no questions, but I want to congratulate Dr. Kaur. This was a totally different presentation I have seen on Botox, and the way she has covered it, it's amazing. And Dr. Kaur, I would like to hear you live someday soon.
Thank you so much, ma'am. This feels wonderful coming from me. And happy Women's Day to all the beautiful ladies that I've been seeing on screen today.
Thank you.
Thank you so much, ma'am.
Hello. Hello.
Yes, Sonal, you are audible.
Audible. I think there was a technical glitch in between.
Yeah, but we can't see you, of course.
Yeah, I have switched off the camera, so maybe that's all right. Is that a question answered? Because there was a technical glitch in between, and Dr. Rumpa
No,
was...
everything is done.
Okay, so now we have one more faculty remaining, Dr. Yeah, just a second. We have Dr. Rakshin Irani. Do we have her here? She is a co-host now.
Yes, ma'am. Am I audible?
You are audible. Can you switch on your camera, madam?
Yes, ma'am. Am I audible and visible?
Yes, you are. And can you just share your screen, madam, now?
Yes.
Please.
Should I, is it visible, ma'am?
Visible. Can you go on a presenter's mode or a slideshow mode?
Ma'am, I've put it on slideshow mode only.
No, dear. Not as yet.
No, on the on the footer, you will have slideshow.
Footer, you just check the footer below. There's a 66% digit that is seen. Just next to it, there is a slideshow button there. Just click on it.
Ma'am, I don't know how to do that.
You just start with your presentation, like
Dr. Dr. Irani, could you place Control F5?
Control
F5.
Control S.
F.
Please press simultaneously Control and then F5 on top of the key
Okay.
actually.
Control F5. Is it
No, do one thing. Continue with the presentation in this format only. Okay, continue.
okay? A very good evening to the esteemed chief guests, respected members of the jury, and senior and junior colleagues and students. I am Dr. Rukshini Irani, and I'll be speaking on artificial intelligence powered endodontics, a new frontier in dentistry. Before I start my presentation, I would like to take this opportunity to thank Dr. Sucheta Sathe, consultant and practicing endodontist at Dinanath Mangeshkar Hospital and Research Center, Pune, who has guided me with the presentation. So basically, artificial intelligence has expanded its role and importance through many industries, especially in dentistry, and it mimics human intelligence. And as a result of that, it facilitates sophisticated forecasting and decision making, which is particularly important and useful in dentistry and more so in the field of endodontics. My paper today will explore the current uses of artificial intelligence in the field of endodontics, the emerging trends that we need to consider for further integration, and also the potential challenges that we need to consider when developing artificial intelligence programs and moving forward. So just a very brief history. In the 1950s, Alan Turing came up with the statement, "Can a machine think?" And he put forward the imitation test or the Turing test. The term artificial intelligence was coined by John McCarthy in 1956. From 1970 to the 1990s, there was an abrupt halt in the development of artificial intelligence, and that is known as the AI winter. And
Dr.
the
I'm sorry to interrupt, but what is happening is you're talking, but your screen is not moving ahead. So maybe you can press the escape button.
Okay.
Okay, and then present it as is, like what you see on your screen, and you present it. Yes, now we will be able to see. Okay, move your screen ahead, like keep on moving as you make your screen presentation along
Okay.
on this same mode
Can you
only.
see the next one now?
Yes. So
Ma'am, I was still on the previous one.
please start from where you discontinued. Start from there itself. Don't go back.
Okay, ma'am. So The 1990s marked the end of the artificial intelligence winter, and then there was a surge of technological development, and people came up with a lot of new programs like Alexa and Google Home and all that. And fast forward to now, we have a lot of artificial intelligence programs which are used in multiple aspects of our daily life. So basically, coming to the artificial intelligence models which are used within endodontic practice, we have something known as machine learning and deep learning. These are the two basic subsets of artificial intelligence which is used within endodontic practice. Machine learning, basically, it is something that enables machines to automatically learn from data without being explicitly programmed. So an example of machine learning is Alexa, though it requires human intervention and there can be errors. Coming to the next one, which is deep learning. Deep learning is a subset of artificial intelligence that simulates the complex learning and decision-making processes of the human brain. So for example, an example of deep learning is recognition of a cat. The program is going to be shown multiple or thousands of images of cats where they can distinguish between the color, the shape, and other features, and that is how it is going to go ahead. Now, coming to the basic working of artificial intelligence. So the basic working consists of images, text, and audio, which are put in as the input data. And you can use the necessary artificial intelligence algorithm of either machine learning, neural networks, deep learning, and all this is processed, and the output is in the form of getting a diagnosis, classification, treatment, and prognosis. So coming to specifically the artificial intelligence methods used in endodontics. So the models in endodontics are neural networks, deep learning, case-based reasoning, and the neuro-fuzzy inferencing. I have already spoken about deep learning. Deep learning can be used to detect periapical lesions and root canal morphology. Coming to neural networks are basically made up of a series of algorithms that calculate signals using artificial neurons. So neural networks basically are artificial neurons which are going to work in a similar manner as the normal, the routine neurons in the brain. And those are used to detect periapical lesions, root fractures, root canal morphology, and working length determination. As far as a case-based artificial intelligence algorithm is considered, it is any computer system that aids healthcare providers in making clinical choices by handling clinical data or medical knowledge. So that is used for prediction of endodontic retreatments. Neurofuzzy inferencing is basically the branch of logic, which is known as a fuzzy logic, and it recognizes and proves that everything is a matter of degree. Fuzzy logic aims to emulate human reasoning abilities when dealing with unclear issues, and therefore neurofuzzy inferencing is utilized in the field of regeneration in endodontics. Now coming to these specific clinical applications, analysis of root canal morphology and treatment planning. Like I mentioned, the deep learning system could be useful in diagnosis and treatment planning. This is a compilation of certain studies which have been done, and we can see that overall artificial intelligence algorithms have shown a superior accuracy as compared to other diagnostic techniques like panoramic radiography and CBCT. Another application of artificial intelligence is in working length determination. Over here, we have machine learning and artificial neural networks, which are used to improve the radiographic working length determination. Also, locating the apical foramen is possible with artificial intelligence. A compilation of literature again shows that the AI methods proved to be more superior to the diagnostic techniques which were used for determination of working length and apical foramen location. It can also be used for prediction of periapical pathologies. Again, deep learning segmentation in combination with neural networks results in a high accuracy. This is a compilation of the studies which have been performed where they have compared artificial intelligence methods with periapical radiographs, panoramic radiographs, CBCTs, and again, artificial intelligence algorithms have shown better, superior accuracy. Prediction of endodontic retreatments can also be done with artificial intelligence algorithms. So over here, we have a combination of machine learning and case-based reasoning, which are going to provide accurate results. Artificial intelligence can also be used for detection and diagnosis of vertical root fractures. As we can see over here, the different softwares of artificial intelligence in comparison to CBCTs and other diagnostic techniques have shown a superior accuracy. And it can also be utilized in regenerative endodontics, where the neurophagy inference system is reliable in predicting cell viability. So basically, if I can give you a very simple example of what is neurophagy inference, it is applied to the working of a washing machine. So that is the principle of neurophagy inference. So it takes into account multiple factors, and therefore it is going to be helpful for regenerative procedures where it helps us to predict stem cell viability. And the next part that I would like to speak about is the future trends which are going to take place in artificial intelligence. So basically, we have something known as photorealistic 3D reconstructions. Ma'am, can I go into slideshow mode for this? Because I have different pictures for this. Hello?
Yeah, please go ahead. Let us see if it is possible now.
Yes. So future trends are photorealistic 3D reconstructions. This is an example of photorealistic 3D constructions. It is an exciting area that has been gaining more interest, and it basically it makes the use of an artificial intelligence enhanced algorithm to create a photorealistic 3D reconstruction of the root canal space and the tooth anatomy, as well as common orofacial lesions. And this can potentially improve the diagnostic accuracy by better displaying the anatomical details.
Doctor,
Also,
your screen is again the same, so maybe you can press escape and start.
okay. Also, another future trend is robotics and microbots, which is basically the development of artificial intelligence guided robots to aid in rendering actual treatment on the patient. Potential challenges that we might face are obviously possibility of misdiagnosis or errors. There's always a need for human intervention. We cannot totally rely on artificial intelligence for diagnosis and treatment planning. Also, if machines are going to take over, then there will be potential loss of jobs for dental professionals. And since it is all based on computers, there can be a breach in privacy and data security. And it could also exacerbate existing disparities in healthcare, because integrating artificial intelligence in our practice is going to cost us a lot. People from the lower socio-economic groups may not be able to avail the treatment which is provided with the help of artificial intelligence. So I would like to conclude by saying that the current artificial intelligence models being researched have several promising applications within the field of endodontics, including the detection of periapical pathosis, root fractures, determination of working length, and prediction of treatment outcomes. It is critical, however, to build these models from data obtained from experienced clinicians to ensure the accuracy and consistency. And when compared to other fields of dentistry, AI usage in endodontics is still relatively sparse, but there are exciting areas that hold further promise for usage growth. Thank you. These
Okay,
are
very
my
well.
references.
Yeah, very well articulated, Dr. Raksheen, but then you have exceeded your time by few minutes. Anyways, not to worry. Okay, any questions, Dr. Vaishali, you have for Dr. Raksheen?
Over to Dr. Sumita.
Dr. Sumita?
Yeah, so while I don't have any questions per se, because this is purely a review paper, and there is no clinical query to find out from you, but I am extremely skeptical, and even I wouldn't want to be quoted on this because I'm not old-fashioned, but I am against artificial intelligence invading the clinical and surgical field, because no amount of artificial intelligence can imitate the empathy and warmth and concern of a doctor.
Yes, ma'am. So I would just like to say that on a personal note, even I agree with that fact, and it is a big disadvantage of artificial intelligence. And I feel that it can only be used as a supplementary aid for dentists in our field. And like you mentioned, there is lack of emotions, lack of empathy, and one very important aspect is tactile perception, which lacks in artificial intelligence. So therefore, I don't think that it can completely take over professionals providing treatment to the patients.
And somebody very smart said that I'm not afraid of the increase in artificial intelligence around the world, but I'm more concerned with the decrease of real intelligence everywhere.
Yes, ma'am.
That is my concern. But other than that,
Yes, ma'am.
very beautiful paper. And my
Thank you, ma'am.
regards to Sucheta, she's a dear friend.
Great.
Thank you, ma'am. Thank you, ma'am.
Rumpa, do you have any question?
No, Sonal, I'm good.
Okay, so all we know is that we are trying to eliminate the AI hallucinations also and keep the emotional quotient or the human quotient alive over here. So way forward, we are going to be dealing with these artificial intelligent factors in our life, and we need to incorporate them. And a very good take on this whole topic, Doctor.
Thank you,
Congratulations.
ma'am. Thank
Okay.
you.
So now we are starting with the students' presentation, and jury, now you can have your all armamentarium out with markings and all. So the first student that we have online with us is Dr. Siddhima. Yeah, Dr. Siddhima. If I'm pronouncing her name correctly, are you online, Doctor? Can you hear me, Dr. Siddhima? Dr. Siddhima, are you there? Dr.
She's
Vaishnav,
in
can you hear me?
she's in meeting room, but she's not responding.
Okay.
She's on mute, I think. Could you tell her?
Dr. Siddhima, can you unmute yourself? Yeah, you're there now. Okay. Starts all these will be marked under time as well as presenting criteria. So Dr. Vaishali Das, Dr. Sumita, and Dr. Rumpavik, please start marking from now on. Okay. We are selecting 3 best papers out of them, the students. Dr. Siddhima, start sharing your screen, please. No, we cannot hear you, Dr. Siddhima. Use the system audio. Forget about those headphones. Dr. Nurul, what is the command for Windows? Her mic has to start.
I think she is there, but she couldn't responding. I'll let's do one thing. Call Dr. Ritika Mehta, and she will join later on. Then
Dr. Ritika Mehta. Dr. Ritika Mehta, are you there?
Yes, ma'am, I'm here.
Okay, Dr. Ritika, can you start your screen video, please?
Yes, ma'am.
Everybody, please switch on the cameras. Dr. Siddhima, unmute yourself and mute your camera also now, for now.
Ma'am, I would like to start screen sharing.
Please do that. And your time will start after you start your screen sharing.
Yes, ma'am.
Please go on presenters mode, slideshow mode. Yeah. Your time starts now, doctor.
I'd like to wish everyone a really good evening and also a very happy International Women's Day. So on today I'll be presenting on my topic adenomatoid odontogenic tumor retrospective study. So what is an adenomatoid odontogenic tumor? AOT is common is it is a non-invasive benign epithelial tumor of odontogenic origin, and it accounts for almost 2 to 7% of all odontogenic tumors, which can also be reflected in our records. It is characterized by slow but progressive growth and is considered to be a hematoma more than a tumor. Clinically, it is seen as a well-defined clinically, it is seen as a well-defined tumor which is mostly present in the second decade of life and has a marked predilection of occurrence in females. It is also known as a tooth-hole tumor, where 2/3 of the time it occurs in the maxilla rather than the mandible and affects the anterior jaw. Radiographically, it is seen as a well-marked radiolucency and surrounds an unerupted tooth, as you can see in the picture. Histologically, it is a well-circumscribed lesion which shows proliferations in the epithelium in the form of a rosette pattern or a ductal pattern. So a rosette pattern is basically a spindle-shaped cells arranged in the form of a nodule, and a ductal pattern shows a tubular structure with a central lumen. The aims and objectives of our study. It is a retrospective observational study where the cases were evaluated from our Department of Oral Pathology from the year 1990 to 2003. And all the cases have been analyzed with their clinical features, histopathological features, radiographic features as well. In the methodology, I'd like to point out that one of the samples was observed under a scanning electron microscope at Icon Labs in Mumbai, and the ethical approval has been received from the institution's ethical board. The data was analyzed and documented using Microsoft Excel and SPSS version 21. The sample size is calculated by a biostatistician, and the sample size minimal is 2. We were curious as to if there were any other cases which were documented in literature and if they had similar findings. The first case we found was by Shivani B. Bansal. It was over a time frame of 50 years and the number of cases recorded were 55. It was a single institutional study which showed a male to female ratio of 1:5, and and only recurrence was seen in one case. Another case was by Felipe Rodriguez in Brazil. So this case showed the presence of a male to female ratio of 1:4 and affected people in the age range of 16 years. The cases recorded were only 15, even though the study was carried over for almost 4 decades. Another case was a very interesting article, was an electronic study which was published in the year 2018. It had a male to female ratio of 1:9, which was a cumulative surge of 1,558 cases. Lastly, I'd like to talk about an article which was published by the Sri Lankan Association, and it was a multi-institutional study which documented the cases in Sri Lanka for over 3 decades. And it also came up to the conclusion that the age range affected was the second decade of life, and the male to female ratio was 1:1.6. Keeping that in mind, I'd like to discuss the observation and results of our study, starting with the histopathological features. The most prominent feature was that the rosette and the ductal patterns were commonly seen histopathologically, as well as certain calcifications were also noticed. As you can see, these are the cases from our we have reviewed. The first one is under 4x magnification and shows a nodular as well as rosette structural patterns. And all of these cases show the presence of spindle-shaped cells in nodules and ductal cells. As you can see here, the ductal pattern as well as the rosette pattern is commonly present. The radiographic features, the most common radiographic feature we found was a unilocular lesion with an embedded canine. As you can see, 3 out of 4 cases were associated with the canine. It had a greater female predelectation, and 3 cases affected the mandible, whereas a general predelectation is seen in the maxilla. Our study showed a predelectation in the mandible. The summary of the findings has been given in a tabulated form. Next, I'd like to talk about the most important feature of our study is the scanning electron microscopy. And SEM is basically an instrument which is used to magnify images using X-rays and backscattered electrons. I can show you, you can see the difference between the rosette pattern observed under light microscopy and observed under an SEM. This is a huge nodule showing spindle-shaped cells embedded within it. Next is this picture where you can see an encapsulation of the tumor, which shows its benign nature. This is another picture which is a 2D representation of a 3D ductal structure with a central lumen and columnar cells surrounding. Lastly, there was an interesting finding during our SCM analysis. We found crystals of sodium, calcium, and potassium in abundance on the surface of these specimens. We do not know as to why these crystals were present, but we have come forth with 2 hypotheses for this. The first hypothesis being it could be because of the long-standing nature of the specimen in a formaldehyde or a preservative solution. And secondly, it has been seen histologically that AOT has certain calcifications present within it. So these crystals could be attributed to the histological presence of those calcifications. Lastly, I'd like to summarize my entire PPT by pointing out the unique features of a study. We not only have seen a mandibular predominance, and we do agree that the duration for our study was long, almost 3 decades. But we would like you to keep in mind that it is a single registry study from the Department of Oral Pathology of our institute. And this is not only, this is the first study to incorporate a scanning electron microscopic analysis of adenomatoid tumors, and not only in India, but also all over the world. So I'd like to thank everyone for, these are my references, and I'd like to thank everyone for patiently listening. I'd also like to thank Pdcon for giving me this platform to present. Thank you.
Yeah, good presentation. Dr. Vaishali Das, you have any question for her?
Not really, because again it is a review study. So because in a theoretical aspect, I don't think so I have any question, but well presented, Ritika.
Thank you, ma'am.
Dr. Sumita, can you unmute? Yeah.
Yeah, just casually asking, I mean, it is not related to your presentation as such, because like Dr. Vaishali said, it is a review presentation. While it was very good, but in the end, you were not involved in it, so I can understand. But just for my knowledge and to see if, if you had that chance, did you get to see a adamantinoid tumor?
Ma'am, this is a retrospective study, so
I understand it's a retrospective study. I want to know if you have seen one.
Ma'am, clinically, we have not seen any of these cases, but we did have the specimens stored. So we have seen the specimens of AOT, and the scanning electron microscopy was of these specimens.
My interest was in wondering if you've seen the case.
No, ma'am, we haven't seen any clinical cases.
Okay. Dr. Rumpa, do you have any question?
No, Sonal, I'll take a pass. But I would just like to confirm, what is the time limit given to them?
5 minutes plus 2 minutes for our questions.
Can you repeat that, please?
5 minutes and 2 minutes for our question
Oh,
answer.
5 plus 2, 7. All right.
Yeah.
Okay.
So
got it.
7.
Thank you.
Okay.
Good
Yeah.
one, Ritika.
Thank you, ma'am.
Okay, so now we will like to call again Dr. Siddhima. One more
Can you
effort.
hear me now?
Yes, I can hear you and I can see you. Very welcome. Okay,
Yeah.
welcome here. Okay, start as soon as possible. Share your screen and your time will start as soon as you share your screen.
I've shared my screen.
No, it's not visible.
I'm getting a message when it's written host disable attendee screen sharing.
Okay, Dr.
Please
Nural,
try again. Please try
please
again. You
try
are a
again now.
co-host now.
You are the co-host now. Yes, go on a presenters mode. What is this, a PowerPoint presentation?
Yeah.
Okay, go on presenters mode, madam.
Oh.
This is an abstract, what I can see.
No, sorry.
Siddhima, you're wasting our time, dear. Siddhima, go back, drink water, come back. We'll call you again.
Relax, Siddhima.
Relax.
It happens. Relax,
Nothing wrong will happen here. Just switch off your screen, go back. We will call the next presenter. We'll call you in
Yeah,
again.
yeah.
Okay.
Yeah.
We want to call now Dr. Asmita Javhade. Dr. Siddhima, can you stop screen sharing? Yeah, Dr. Asmita.
Yes, good evening, ma'am.
Yeah. Please start your screen sharing.
Yes, ma'am.
Okay, your time starts now, doctor.
Yes, good evening, everyone. My topic is attitude of dental practitioners in Marathwada region in radiographic post-operative assessment of dental implant. For this introduction is attitude in radiographic post-operative assessment of dental implant. Implant prosthetic rehabilitation has become a widespread in clinical practice over the last 20 years. The dental implant showing a great success rates in the management of complete or partial edentulosum. Periapical and panoramic radiograph represent the accessible and quickly and low cost imaging technology available in the almost every dental office. For this, the aim of this cross-sectional study were to investigate these habits and the knowledge about radiographic aspect of retrograde peri-implantitis among the dentists. Going to the material and method part, this research study was conducted in Marathwada from January to March 2024. We aim to evaluate the dental professional knowledge, attitude, and practitioner regarding radiographic post-operative assessment of dental implant in Marathwada. 215 registered dental practitioners participated in cross-sectional close-ended questionnaire-based survey. The questionnaire was conducted the previous studies, which contain 4 multiple choice questions regarding the radiographic post-operative assessment of implant. The questionnaire was distributed through the online portal Google Form. The data of 250 field Google Form was analysis. Going to the result part, after the result which I was expecting, I have giving them 4 questions. The result were as you see on the screen. The in that the more than 50% preferred dentist to take IOPA over the CBCT and OPG. Next question. So, in order to find the radiographical assessment of the peri-implantitis, it was found that the majority of dentists prefer the radiolucent area at the apical aspect of the implant. And the third question is the success and the failure of implant depends upon the radiological bone density. For this, we need to take the X-ray at various time of interval in order to get self-confidence. Immediately X-ray is been taken. In my studies, similar to the thing observed, the majority of dentists take X-ray immediately after the surgery. The modern imaging facility like CBCT, CT scan, MRI are readily available and known to many of us and give 3D images, pictures. So I asked question about it. Then more than 80% dentist answer yes, and remaining says no. For this, going to the discussion part, over these years, the radiographic imaging has become a fundamental tool in dentistry, in particular in implant dentistry, where it is used to assess bone height, bone resorption, the proximity of the maxillary sinus floor, and the neurovascular landmark. The aim of this cross-sectional survey was investigate the attitude and the habit of population of dentists in radiographic imaging in implant dentistry, and their knowledge about the radiographic aspect of retrograde peri-implantitis. Based on the results of our study, intraoral and periapical X-ray is the more widespread radiographically performed, which is similar to the studies of BD Muro. Based on the results of our study, the majority of dentists perform X-ray immediately after the surgery, which is similar to the study of AS Lingam. For the radiographic aspect of retrograde peri-implantitis, which is similar to the study of PA Mansour. Uh, for this, going to the conclusion part, the appropriateness of the radiographic perception habit among the dentists is extremely important. The radiography is considered the most used diagnostic tool in dentistry, accounting for the almost quarter of the total X-ray in medical field worldwide. The proper and rapid diagnosis of peri-implant disease and implant post-operative complications is the paramount importance for the long-term implant survival and success. Thank you.
Okay, well within time. Dr. Vaishali, do you have any questions for her?
Yeah, good one, Dr. Asmita. I just want to know why was such a study conducted at all? What was the need of doing this survey? And how does it help you clinically?
Actually, ma'am, many of us in our clinics, not CBCT center is that for available. And after implant placement, the importance of X-ray and rather than importance of radiographic aspect, I think, so that I want to study for this.
But I can't see any clinical implication of this thing. But nevertheless, it's okay.
Dr. Sumita, do you have any question for her?
Actually, what Dr. Vaishali asked was exactly what was on my mind. That,
Actually.
Are convinced about the relevance because radiography and CBCT are now absolutely the norm. There is nothing that any clinician can say about not being aware of radiography and CBCT. In fact, I think higher centers are moving even ahead.
Yes.
Yeah, at radiography and CBCT, we are just at the baseline. We will be going even beyond very soon.
Yes, ma'am.
Dr. Rumpa?
Yeah, I like what she said, but yeah, there can be a more weaving. That's what I felt. So, but overall, I love what she started. She's just a student, right? Which college are you from?
Ma'am, actually, I doing fellowship in implant, oral care,
Okay.
Sambhajinagar. Yeah.
Okay, wonderful. Keep going.
Thank you, ma'am.
Great. Now, Dr. Siddhima, again, one more chance to you, dear. Have you had
Yes,
your glass of water?
Yes, ma'am.
Okay. Now, don't worry, dear. We are not going to come and hit you over there. And none of us are that kind of teachers that will come and punish you there. Okay. Now, please switch on your camera, dear. I would like to see your face. I would like to see that
Yeah,
relaxed again. Where are you?
Yeah.
I cannot see you. Okay, great. See, now smiling Siddhima is back again. So, Siddhima, start sharing your screen.
Yeah. I've shared my screen.
No, dear. Dr.
Siddhima, your video is looking off from here, from our screen.
Doctor.
In fact, none of it is visible better, neither your screen nor the presentation.
Dr. Nurul? Okay, great. Okay, now can you go on the presenters mode or slide share mode, please? Very beautiful color combinations you have used. One of my favorite colors, Siddhima. So your time starts the moment you share your screen.
Can I start?
Yes, please go ahead.
Yeah, okay, so good morning. My topic for today is microcosms in a chip, unveiling insights through organ on a chip model. So basically, today I'll be covering the introduction, key concepts, case studies and current applications, advantages, challenges, and future directions of the topic. So, in contemporary research environment, efforts have been taken to replicate intricate physiological environments in vitro, aiming to establish a more sophisticated and effective platform for scientific investigations. Enter the topic of discussion, that is organ on chip. It is also called as microphysiological systems or tissue chips. So basically, organ on a chip is a very intriguing scientific and technological development that merges the most cutting edge developments in biology with technology, specifically microtechnology, to emulate crucial aspects of human physiology. This is basically the definition. Organ on a chip is a microfluidic system with intricate microchannels guiding and manipulating small solution volumes, which is basically in picoliters and milliliters, to support cultured microtissues. So, what exactly is the key concepts? What do we require to make an organ on a chip model? So basically, in general, the picture here describes a two organ system. It requires four steps in general. First is conceptualization and design. Second is material selection and fabrication. Third is selection of biological elements. Fourth is supporting life inside devices. So all four of these steps are very dependent on what exactly is the function of the organ on chip device that we are supposed to make. So for example, conceptualization and design. It could be a barrier type organ, which is that cells are cultured on an ECM coated membrane. Second is a 3D cultured tissue, which would be an organoid with parenchyma, as observed in the diagram shown. Then the material selection and fabrication, which is again very dependent on what is the function of the model, and it is based on the material selected. The way we sterilize uh, is also unique to that model. So the most commonly used material is PDSM, that is polydimethyl siloxane. Then the selection of biological elements. It could be an induced pluripotent stem cell. It could be an adult stem cell. Then supporting life inside devices. So an organ on chip device is very sensitive in nature, so it has to be remotely be controlled using certain devices, such as mechanical stimulators, controls and sensors, incubators, etc. So the current case studies and current applications. So first, let me explain the A part of the diagrams. So first, the A part is depicting a gut on a chip device, which is inspired from transwell assays. What exactly is a transwell assay? Transwell assay is basically a very traditional model which is used to understand and study intestinal absorption, drug absorption for orally administered drugs. The device basically contains a permeable membrane on which intestinal epithelial cells are grown, and it has a compartment above and below this membrane. The above membrane mimics the gut lumen, and the below compartment mimics the vascular lumen. So the similar device is depicted in the microfluidic manner, wherein the two static compartments are exchanged for two micro channels, as you can observe in the diagram. So normally in a general gut on a chip device, the cells used are COCO2 from COCO2 cell lines, which is from colon carcinoma cells, and the material used is again a PDSM. The other B and C part of the diagram basically describe a multi-organ on a chip device, which basically stimulates multiple organs on the same device. It is so as to better understand the interaction between different organ systems rather than just studying the biological function of a single organ system. So finally, these are certain there are certain other ongoing case studies and applications. For example, there is Humayun et al. There is Humayun et al. Basically uh, developed the lung airway on a chip, and to study the interaction between smooth muscle cells and epithelial cells. There is her et al. Who basically made a pulmonary edema on a chip. Then there is there is also Bai et al. Who basically were able to demonstrate physiological correlation between the mechanical breathing motions of lung tissues with host innate immunity. And actually, there are also a lot of current case studies even in dentistry where Christine was a scientist. Him and his group basically they studied the interaction between dentine and pulp, and there are also other such functions which are ongoing. So advantages which I believe organ on chip device have over traditional models is that it can replicate physiological and pathophysiological environment in a more accurate manner. It has a high throughput screening is possible, and the integration of automation and smart analysis system is also more possible. So animal models are not exactly similar to how human physiological system act. So this is a more accurate model according to me. So what are the current challenges? First is cost. It requires a lot of monetary involvement. Second is complexity of tissue replication. It is very difficult to replicate the organ tissue, the micro tissue that is grown on the chip. Third is integration of multiple organs. Though there are certain multiple organ on a chip devices which integrate multiple organ systems, it is not as cohesive in current times. Then there is long-term viability. It is not viable for long. Standardization and reproducibility. At the moment, this is still not possible. Ethical and regulatory consideration, considering the fact that the micro tissues that we are using are growing on the chip. It is through human donated cells. So there are certain considerations required, which at the moment are not taken into note. Then future directions, according to me, would be better multi-organ integration, inclusion of neural network, integration of multiple organs, usage of better materials, individualized disease modeling, possibility of scaling up. So basically, in conclusion, I would like to say that the transformative potential of organ on a chip technology lies in its capacity to replicate microscale physiological environments, offering unprecedented insights into disease mechanisms, drug responses, and biomaterial compatibility. While currently emphasizing drug development, OOC platforms also prove invaluable for studying biocompatibility and efficacy of biomaterials. Beyond this, these systems provide a human-centric approach to scientific investigation, overcoming interspecies differences as observed in animal models in data extrapolation. In essence, OOC technologies represent a paradigm shift in biomedical and pharmaceutical research and development. So these are my main research. Like I've actually read multiple research papers on this, but these are the main references. Thank you.
Okay, great one, Dr. Siddhima. So worth the wait. Okay, Dr. Vaishali. Dr. Siddhima, can you switch on your camera, please?
Oh, yeah.
Dr. Vaishali, any questions?
Yeah. Siddhima, it was a very nice presentation. Excellent
Thank you, ma'am.
delivery, I must say.
Thank you, ma'am.
I don't have any question on it because I don't know anything about it, so I would rather pass it on to Dr. Sumita or Dr. Rumpa if they know more about it.
Dr. Sumita?
I would like to know if you have understood its specific relevance to dentistry.
Okay. At the moment, according to me, the most important relevance could be like basically for testing the dental materials that are used. So normally for a dental material to come in market, it takes a very long process. A lot of steps, a lot of red tapes to cross. So I think this would reduce that time because like rather than animal testing, we would be using a organ on the chip device. So the difference would be the animal testing, the animal's immunity system is very different, and the organ on a chip device would try and mimic the human physiology more accurately. So in clinical trials, the errors that come into place would be reduced. So we can have a more targeted clinical trials, thereby reducing the time it takes for the dental materials to come in practice. That's one of the.
Be a little bit kinder to the animals also.
Yeah, definitely.
I like
I do not advocate animal studies whatsoever.
Yeah, same. So
I
according
do
to
not do animal studies. Think you have been if someone is doing a trial on you.
Yeah,
I mean,
definitely.
it's a very personal thing, but I just
No, I agree 110%. This is one of the reasons I actually started studying on this, because I think this is a more humane way of doing things, and like it would help humans in general. Like you're not harming animals, firstly. Second, you're reducing the amount of time it takes for all these drugs to come into market, thereby also helping people in general. For a lot of diseases, we still don't have drugs targeting them, and dental materials specifically, as I said.
While the concept was very heavyweight, I must say, but I like two things. I like the way in which you worked hard to understand, because at your level, understanding the complexities of this technology is not easy. So you have done a good job, because the way you have spoken, it's very clear that you have understood what it is. And the second thing I like a lot is you have your heart in the right place.
Thank you so much, ma'am. Thank you.
It's a rare thing these days. So, yeah.
Dr. Rumpa, do you have any questions for her?
Oh, no questions, but this was absolutely a learning curve for me. Siddhama, your topic was pathbreaking. And as Sumita and Vaishali, both of them said, you are going to carve out a niche very soon in life. Gear up, girl. All the best.
Thank you so much, ma'am. Thank you so much for your kind words. Thank you.
Very good, Dr. Siddhima. Now we have next in line Dr. Doshi. Dr. Doshi, are you here?
Yes, ma'am.
Yes. So start sharing your screen, and your
Yes,
time
ma'am.
will start as soon as you share your screen.
Ma'am, can you see my screen?
Yes.
Okay. Good afternoon to one and all present here. My today's topic is aeronautics in dentistry, navigating oral health challenges in zero gravity. So let's know what is aeronautic dentistry. It is a specialized branch which is focused on the study and management of dental health and related issues in aerospace environment. So these are the few contents of my presentation. Let's talk about the changes that are induced in orofacial regions. These are some of the changes that are induced. Let's talk about the bony changes. So the bony changes that they undergo is osteomyelitis. This is because of the reduced amount of blood supply. Next, we look at the temporomandibular disorders. This is because of the disturbance in the cortical regulation and melatonin secretion, resulting in bruxism, muscle pain, dental and periodontal damage. Next is trauma. As I mentioned earlier, that the bone density decreases, which will make the jaw bones more vulnerable to fractures. Next is masticatory muscle atrophy. So all the muscles of mastication, such as masseter, temporalis, medial pterygoid, atrophy is seen because of the diminished utilization, which will cause muscle weakness and degeneration. Next is the salivary changes. Since the muscle tone is decreased, there is the squeezing action of the gland decreases, which causes xerostomia. Also, we have calcium deposition, which will cause sialolithiasis or salivary stones. Microbial changes. As you know, the higher you go in the altitude, oxygen level depletes, which will cause more amount of anaerobic bacteria to grow, causing these are some of the bacteria that grow. Next is altered immunity and infections. Since there is alteration in the distribution of the WBCs, which are the first line defense cells, the efficacy of T cells, physical strain, isolation, all these factors together alter the immunity and make them more prone to infections. Next we talk about is the decompression sickness. This is caused because of the formation of a gas bubble, which is nitrogen, within the blood or the tissue, which causes them joint pain or muscle pain. This happens due to varying degree in the pressure levels. Next is free radical activity. This is because the astronauts and the aircraft, both of which are affected with lot of radiations. Next is change in drug metabolism. So there are certain common drugs which are perceived as not effective once they return from the flight. Secondly, they have to take a dose of sleep-inducing medications post-flight in order, because they are sleep deprived. Also, there is altered absorption and lower bioavailability of some common drug like paracetamol. Endo and perio lesions. So all the factors I have mentioned earlier together contribute to an endo and perio lesion. Next is dental barotrauma. This is because of the pressure differences in which a gas or a void is formed below the restoration, which on pressure changes can expand or contract, causing pain. This is a similar phenomena where a dental pain is triggered, but in an asymptomatic or an already treated tooth, because the air bubble can enter the pulp and aggravate the pain. This is a summary of all the factors that I have talked about, how each factor is interlinked with each other. Next is which astronaut will be able to go for the spacecraft. So they are divided into 3 categories based on the oral health: class 1, class 2, and class 3. Class 1 and 2 are the ones which are fit to go. There are different steps in which they have to brush. It is not ordinary like we brush. The water will come from the bag, not from the sink. They have to swallow the toothpaste. They cannot spit it out. And the last is the toothpaste tube has to be stuffed down, otherwise it will float. So the dental treatment pre-flight considerations are, if they have to do, then they have to do a root canal treatment to avoid any pain further. Fibrin-based adhesives must be used in order to control hemorrhage. Any cementation of the prosthesis must be done with resin cementation other than the ordinary cementation. And if an astronaut is undergoing an extraction, it has to be careful that there is no oroantral communication. These are some pre-flight quantum measurements that an astronaut has to take before it goes, such as comprehensive vaccine regimen against infections, aseptic insertion of bladder catheters, prolonged ingestion of sterile fluids, which is done with gamma radiations, routine health screening, pre-travel infection control, and isolation from the community before launch so that they do not carry any infection. These are similar points that I have summarized ahead. Next is the measurements they have to take during space travel. This is for the aseptic conditions like wearing masks, having gloves, using germicidal wipes, and non-alcohol based sanitizers. Also, they have to perform certain exercises so that they remain fit. These are similar points that I've mentioned earlier. These are some of my references. Thank you for patience listening.
Which year are you in, Doctor?
Ma'am, I'm an intern.
Intern. I wish you could go to Dr. Gaganyaan and speak to those astronauts over there also, and you be their dentist. All the best for your future. And Dr. Rumpavik, I would like you to ask some question to Dr. Toshi here.
Yes, Drashti, hi. Just loved what you said.
Thank you, ma'am.
Just guidance for you, no questions, because barodontology is something, it's very important even when we are flying high altitudes and all. But if you could connect to Guru Nanak Institute in Kolkata, they have just received their first patent named Barodontologia Prevention Apparatus.
Okay.
You will get more clue if you have some friends, connect with the college. If you want
ma'am.
help, I'm there for you.
Thank you, ma'am.
Because this is something which needs to be explored more, and you opened up beautifully.
Thank you, ma'am.
Lovely, Drishti. Lovely.
Thank you, ma'am.
Dr. Sumita?
Yeah, so very nice presentation.
Thank you, ma'am.
I would have, loved it if you did 2 presentations, one for astronauts and one for routine air travelers like you and me. Maybe one for the Bombay Delhi flight wale people. Very okay, thank you.
Thank you,
Dr. Vaishali, do you have any question for Dr. Doshi?
Not
here?
really, but I would really like to appreciate for choosing this kind of out of the way topic, because this awareness is really important and totally in sync with what Dr. Sumita said. Because there are a lot of instructions that we give post extraction, post implant extraction for the domestic
Take a
pliers.
minute here and thank our mentor, actually, Dr. Vaishali.
Sorry?
Dr. Sandhya ma'am is here and she is the mentor.
My mentor is Dr. Sandhya ma'am.
Yeah.
Guided me all through with this topic, how to say, what to include, what not. Actually, this is a very wide topic. I had a lot of
Absolutely.
information, but because of shortage of time, I couldn't add a few things. Like I know what are spacecraft things that have to be installed so that they do not, get exposed to oral cancer. But since the time was allotted accordingly, so I had to restrict my information.
No, nevertheless, next time maybe we will call you as a speaker.
Very good.
Yes, ma'am. Thank
Okay.
you so
So
much,
thank
ma'am.
you so much. And Dr. Sandhya, ma'am, I would say thank you for giving these gems to us, and because these topics are really different and they are really making us think a lot. Like, yeah, this the purpose of this congress is served today. Next, we have Dr. Jacqueline. Is she there? Dr. Jacqueline?
Yes, ma'am. Hello.
Yeah. Okay. Can you switch on your camera, dear?
Yes. Hello.
Everybody, all the presenters, please switch on their camera once you start presenting.
Should I share my screen?
Please do that. Your time will start as soon as you share your screen, dear. Go on a slide share mode.
Okay. Should I
Perfect.
start?
Yes, your time starts now, doctor.
First of all, a very good evening to everyone present here, and very happy Women's Day to all the beautiful women present in this conference. So I'm Jacqueline Pereira, UG first year right, and I am going to be presenting on the topic myths in dentistry. Mysterious myths. Are they true facts or fake facts? No one really knows for sure. All these stories have been passed down from generation to generation, makes a person wonder why. Dental problems are among the most ancient and widespread diseases affecting mankind. However, most of us, even the highly educated, have certain preconceived notions about our teeth, which, more often than not, are quite distinct from the fact. Good evening, everyone. Today, I will be speaking on the various myths that come across in our field. And through this presentation, an attempt is made to shed light on some of them which we encounter in our routine dental practice. So let's begin. The harder you brush, the cleaner you'll get your teeth. I used to always feel that if I brush my teeth really hard, my teeth will get whiter and cleaner. We all feel that, don't we? But this isn't true. Our teeth are in bathroom tiles. They won't get whiter by overbrushing. Overbrushing can abrade the enamel. If your gums are bleeding, then don't brush them. Our gums bleed due to inflammation. Often it happens when bacteria and plaque get stuck in our teeth. If our gums bleed, we shouldn't stop brushing. Rather, we should brush our teeth but do it gently. Gum bleeding also happens due to the hormonal changes during pregnancy. Bad breath is because of no brushing. People often have a misconception that if they do not brush their teeth well, they will have bad breath. But this isn't true. Having bad breath can be due to various factors like having pungent food, having dental problems like a poor dental hygiene, problems like constipation, acid reflux, throat and sinus infection, and also smoking. White teeth are healthy teeth. It's a common misconception that teeth that are pearly white are healthy. People don't have the same natural color of their teeth, so having white teeth isn't the standard for good oral health. Natural tooth color varies in lightness and is especially dependent on our age. The primary indication of good oral health is having zero cavities and a fresh breath. Fillings have a short lifespan. Dentistry is constantly evolving, and with our evolution, new methods of fillings have been introduced. Modern composite fillings are strong and durable and should last between 10 to 12 years. A requirement to maintain good fillings is to follow the advice of a dentist when they give it to you. In general, though, maintaining a good oral health is all that is needed to keep your fillings strong. Sugar-free drinks are safe for teeth. A lot of people select diet options of popular sodas with the belief that the sugar-free will prevent the tooth decay, and which are often associated with the sugary drinks. Unfortunately, sugar-free drinks can potentially harm your teeth as much as the full-fat alternative. The acid that is present in the sugar-free drink acts at the same way as the acid formed in the full fat drink does. It weakens the enamel of your teeth over time, creating problems for deeper issues to take root. Placing an aspirin tablet or a glove next to your tooth will relieve toothache. Do you massage your head with aspirin paste when you're suffering from a headache? No, right? Similarly, you shouldn't apply aspirin paste directly on the aching tooth. It releases acidic chemicals that will burn your gums and lips. Other home remedies like tea tree oil and clove can be used, but it will only give temporary relief. Moreover, there can be a major cause that's causing the toothache, so it is best to visit the dentist. Dental treatment should be avoided during pregnancy. There are old grandma tales that tell us that dental treatment should be avoided during pregnancy. However, it is medically proven that routine dental treatment can be carried out in all trimesters with precautions, but ideally it should be done in the second trimester. X-rays can be taken, but a lead apron should be used that doesn't allow radiations to pass through. So what's our conclusion? Dental myths can prohibit a person from pursuing healthier oral and dental care and may gradually cause bigger problems. Importance should be given to oral health education at an individual as well as a community level regarding the myths so that the behavior modification can increase the oral awareness and the dental care utilization rate. So accept the fact that dentistry is not expensive, but neglect is. Thank you.
So very well presented and congratulations. This must be one of the first presentations for you in this dental world. So welcome to the dentistry world. And I would like to ask the mentor of all mentors who motivates every student around, Dr. Rumpa, because she would have many questions for you or maybe an encouragement thought for you.
Absolutely. And Jacqueline, if I'm not mistaken, you're first year, right?
Yes, ma'am.
First year, when at least I was there, I had absolutely no clue what I'm going to do later on. I'm being honest. Seeing you right now in this position, hats off to you and girls like you. You really empower us. I just have a small observation to make on one of the slides where you said, yes, all teeth are not naturally white. But since we can whiten the tooth, and why am I saying this? Because just next week I have a full day lecture and workshop on whitening in Pune. So we can change the value of the tooth and we can make the teeth look younger. So lots to communicate with you, but seriously, hats off. At first year, if you're doing this, I don't know what you will do later on. Hats off, hats off, hats off. Really loved it.
I'm just making my future presenters ready for the conferences.
Amazing they are, amazing. It's a learning curve for me.
Yes. And Dr. Vaishali, any thought for
Excellent,
you?
Jacqueline. Whatever Rumpa said, I really concur with that. And you having the grit and determination and the guts to present at this level is something that I would really love to appreciate. And the way you spoke was also really good. All the best to you.
Thank you.
We'll do much, much better in the future life.
Thank you, ma'am.
Dr. Sumita?
So I can only add that I am excited about Jacqueline because from next year she's going to be my student.
Oh, wow. Wonderful. I think we have gems over here and that mentors behind them, right? So now I know where the things are coming from.
Very excited because to have such a self-motivated person, it's a pleasure to teach such a person. So Jacqueline, I'm looking forward to your second year.
Thank you, ma'am.
Wonderful, wonderful, wonderful. Welcome to Dentistry, Jacqueline.
Thank you.
Lots to see from you. Okay, next in line we have Anushka, again a first year student. And again, is Dr. Anushka here?
Yes, ma'am. Just a second.
Yes. Is that a Brahma Kamal? A beautiful one. Then.
Yes. Yeah.
Okay, I would like to see your face, dear, now, but oh, great, Anushka. Okay, start sharing your screen, dear. Dr. Anushka is also a first year, right? And a very chubby girl and very, very, very bubbly girl, I would say. So, okay, Anushka, please share your screen.
Yes, ma'am. Is it visible?
Yeah. Your time starts now, Anushka.
Okay. Good morning, dear judges, and all the beautiful women present here. A very happy Women's Day to you all. And today, I, as a first previous student, will be talking about the mysteries of tongue health and its pathologies. Because as budding oral physicians, this topic plays a crucial role as it would not only deepen understanding, but would also empower us to diagnose and treat a diverse range of conditions. So the tongue might seem small in size, but it is mighty in function. From helping in mastication and secretion of saliva to playing an important role in speech and taste sensation, the tongue does it all. As oral physicians, it is very important for us to know the anatomy of the tongue. It is a muscular organ which is highly vascularized. Structurally, it has two surfaces, the dorsal and the ventral surfaces, and two lateral edges. The dorsum of the tongue is divided into two parts, the anterior two-third and the posterior one-third by a V-shaped groove called the sulcus terminalis. And as we know, the tongue is a specialized organ as it bears several papillae for taste perception, and they are present on the anterior two-third, and they collectively bear over 10,000 taste buds. The nerve supply includes the lingual nerve and the chorda tympani for the anterior surface, and the glossopharyngeal nerve for the posterior surface. And all the other muscles are supplied by the 12th cranial nerve, except for the palatoglossus, which gets the innervation of the 10th cranial nerve, which is the vagus nerve. Starting off with the various disorders of the tongue, the first one in line is the ankyloglossia, which is also known as tongue tie, and it's a congenital anomaly. So in this disease, the lingual frenulum attaches to the tip of the tongue and becomes very short and thick. So it tethers the tongue to the floor of the mouth and it hinders the tongue's mobility. This may also lead to diseases like gingivitis because tongue is also used to remove food debris from the teeth. And in infants, it affects the breastfeeding and may cause pain to the mother too. The next is hairy tongue. So usually what happens is that the filiform papillae, which are keratinized, they shed off timely. But in this condition, the exfoliation that does not happen, and it leads to accumulation of keratin, which gives the hairy appearance. So it is not the teeth present on the hair present on the tongue, but it is the long papillae which appear as small black colored bumps, which become bigger and resemble hair. So it is due to various reasons, including having a soft diet, which causes less abrasion, and abnormal healing after an injury to the dorsum. The next is geographic tongue. This condition is also due to the papillae of the tongue, and on some patches of the dorsum, the lingual papillae degenerate and are eventually lost, and hence these patches appear red, and they also have a slightly raised borders, giving them the map-like appearance. The patient might feel a burning sensation upon eating anything spicy or any acidic food. And this condition is also seen along fisher tongue or psoriasis. The psoriasis is basically a condition, a skin disease causing itchy, scaly patches. The next is fisher tongue, which progresses with age. It is a harmless and non-contagious condition which affects the dorsum of the tongue. It is characterized by deep furrows and grooves, which are usually 2 to 6 mm deep, and it makes the tongue appear cracked. So the main cause remains unknown, but it is seen in cases of a genetic condition, also in Down syndrome. The next is oral candidiasis. It is a fungal infection caused by the overgrowth of fungus Candida albicans in the mouth. Typically, it presents as creamy white patches or plaques on the tongue, inner cheeks, palate, or throat. And its causes include smoking and low immunity. The next is oral leukoplakia. It is a precancerous condition characterized by thickened white patches or plaques on the tongue and can also spread to the gums and cheeks. So it might look similar to candidiasis, but it differs in the sense that it is painful and not easy to wipe off. And histologically also, it will show cancerous features compared to that of the hyphae of the fungus of oral candidiasis. The exact cause of oral leukoplakia is not fully understood, but it is strongly associated with tobacco use, particularly smoking. The next is tongue cancer. So basically, the uncontrolled growth of the cancerous cells in the tongue is observed. And histologically, we can see the keratin being accumulated within the epithelium, and the keratinocytes also show amyloidosis and abnormal keratinization. So lastly, I would like to conclude by saying that a journey through the tongue anatomy and its diseases shows that dentists do much more than just be a daat ka doctor. And I would also like to thank the organizing committee and the team of Pdcon to give me the opportunity to present here today. Thank you.
Lovely, Anushka. And I'm sure Dr. Sumita, Dr. Vaishali, and Dr. Rumpa would be so proud of you presenting here today, as I am proud of you. So now, Dr. Sumita, I am sure you're going to catch another student of yours. And yeah,
I was about to ask her what college she's from.
don't worry, she's going to come to you only.
What college are you from?
From DY only, Nehru.
Yes. So I get another exciting and potentially, gold medalist somewhere.
Very good, lovely. Dr. Sandhya, can you switch on your camera, ma'am? Because she is the instrument behind all these students. I would say
Yeah.
she's the one who's guiding them all.
As always, I feel.
Yeah, Dr. Vaishali, what do you have anything for her? Or should we just?
Anushka, it was really nice, and thank you. Brushed up my anatomy after a very long time, and the oral lesions also. So there's nothing really to ask because this is a theoretical paper, and it is what it is.
Yeah, Dr. Rumpa.
Yeah, hi. Again, I conquered. It was a revision for me. You know, a quick, nice, and packed up revision. I really loved it.
Comprehensive.
Thank you,
Way
ma'am.
to go, girl. Way
Thank
to
you
go.
so much. Thank you so much.
Wow, lovely, Dr. Anushka. And I'm
Sumita, you are
glad
so lucky. You are so lucky.
we are lucky.
Not getting the gems. Oh my God. This is so
we are
amazing.
lucky that we
No,
are witnessing.
the children are very lucky that they are getting guidance from Dr. Sandhya. Like,
Yeah.
she's really putting her heart and soul into their presentation.
Yes.
Thank you so much, madam.
True that.
Here I get all these little wonders to teach.
Yes, yes, Dr. I can see that eagerness in Dr. Sumita. Let them come to me. They are my gold medalist. Yeah. Great, great, great. Next in line, we have another gem coming up, and she would be present. Just let me. That's Dr. Thilaga, and she's from Savita Dental College. Dr. Sandhya, I could see her online. On her camera was online, and Dr. Sandhya, ma'am, thank you so much. Dr. Thilaga, can you?
Yes,
Yeah.
ma'am.
Yeah, I can see you. Can you switch on your presentation?
Yes.
Share the presentation. Dr. Thelaga, you are what, a PG student?
I'm a first year PG student, ma'am. I'm
Oh.
doing my first MS.
Oh, great. Dr. Sandhya, ma'am, hi.
Hi, Sonal.
Great, great. Ma'am, thank you so much for providing us with such beautiful gems to look forward to. And as I was saying, that 18-year-old me, I was judging her, like, have I done her proud? And I can see these girls around. Thank you so much, ma'am. Thank you so much.
Thank you, Sonal. Thank you.
Dr. Thelaga, can you now share the screen, please?
I'm trying to share.
Yeah. Can you see that green button over there? Share screen button?
Let's try. Not able to.
Can you see the screen, share screen button, madam, there?
Ma'am, I'm just trying to say, share.
Okay.
Yes.
Dr. Thilaga, you can open your folder presentation and then try to share your screen. That might be come on this live actually.
So is my screen visible now, sir?
No, not yet. Share screen after opening the presentation.
Sorry, I'm not able to. Can you please give me some time?
Okay, we'll call in the next presenter, Dr. Juhi. Ma'am, you can take a minute and come back later. Okay. Dr. Juhi, are you there? Dr. Juhi?
She's not there. Can we start with Sanvi Shri for poster presentation and
Okay.
we'll take later on.
Now we have poster presentation and we will call back Dr. Thilaga after a while. And poster presentation, the time limit is 4 minutes only. Okay. So the first presenter is Dr. Sanvi. Dr. Sanvi, are you there?
Yes, ma'am. Am I audible?
Yeah, you're very much audible. Now please share your screen, dear.
Sonal, sorry to interrupt. Is this also competitive?
Yes, poster is also competitive. We'll be selecting one out of them.
Okay.
Is it visible, ma'am?
No, start sharing your screen, dear. I can see your face, of course. Can you see the share screen button, dear? Yeah.
Is it visible, ma'am?
No, okay, yes. Go on a presenter or slide share mode.
Is it visible, ma'am?
It's visible, but go on a slide share mode, dear. Just next to 28. Not the full screen mode. Below you'll see a slide share button. Just yeah, down you'll see that. The third button, third. The one the no. No. Go back. Press escape. Okay, go back. No, this is
Completely one page, ma'am, actually.
okay. Go back to your presentation. Go back to your presentation. Present from there itself. Press escape. Go back to your presentation.
Is it visible, ma'am?
Not yet, dear.
Shall I start, ma'am?
No, it's not visible, dear. Go back. Start again. What? Okay, again, share screen.
Is it visible, ma'am?
No, dear. Dr. Nurul, should we call in the next speaker and give her a minute again?
Yes, please.
Okay, Dr. Juhi, I can see her now. Dr. Juhi, are you there? Dr. Juhi, I just saw you sometime back. Okay, we have the next presenter for poster presentation, Dr. Shefali. Are you there, Dr. Shefali?
Yes, ma'am.
Okay, please switch on your camera and start sharing your
Yes,
screen here.
Ma'am, can you see the screen?
No, not yet. Yeah, I can see the screen and your time starts now. You have 4 minutes.
Yes, ma'am. Good evening, respected jury and fellow contestants. Wishing you all a very happy Women's Day. I'm Shifali and I shall be presenting on the topic sports dentistry, protecting smiles and enhancing performance. Sports dentistry is the prevention of oral and facial athletic injuries and related oral disease and manifestations. It is a crucial and often overlooked aspect of athletes' health and performance. As athletes push their bodies to the limit, they also put their oral health at risk. From the impact of contact sports to the dehydration effect of endurance activities, athletes face unique dental challenges that require specialized care. When it comes to people's perspective, they usually associate sports dentistry with the use of mouth guards, but there is so much more beyond it. With regards to this, let us deep dive into the relationship between sports and dentistry. According to regulations, a dentist's role is mandatory in sporting events such as boxing, taekwondo, and is recommended in martial arts, football, and basketball. One might ask, how does poor oral health impact athletic performance? Oral health affects quality of life and well-being, two key elements for strong athletic performance. Energy beverages and supplements contain added sugars and acidic ingredients which can cause caries, hampering the performance. Defective dental occlusion affects posture and gait and increases the risk of injury. Gum diseases can increase diabetes. Eruption of wisdom tooth or infected tooth before the competition can cause poor performance. The face is highly vulnerable. Athletes are projected to have 10% risk of being injured in the face or mouth during the season of play. Some common injuries a dentist might deal with in sports include soft tissue injuries. Abrasions, bruises, and lacerations are frequent and should be investigated to rule out fracture or other severe injury. These include, they usually occur over a bony prominence of the facial skeleton. Lacerations are also common. Most hits to the jaw does not cause mandibular fractures but causes TMJ dislocations. It leads to intercapsular bleeding, which causes joint ankylosis. Tooth intrusions happens by an axially directed effect when the tooth has been pushed into the alveolar process. It may cause 96% of pulp necrosis. A most widespread permanent dental injury is crown fracture. It may have extended to dentine and are usually sensitive to high temperature as well as other stimuli. A severe crown fracture induces the exposure of pulp completely. Amongst the most severe sports-related dental accidents is the full avulsion of a tooth. It is the complete displacement of a tooth from its socket in the alveolar bone. General procedure before the clinic includes asking personal details, checking CNS response, checking patient's general health and parameters. In the clinic, you would check disturbance in bite, tooth's reaction to reactivity, level of pain experienced, and come up with a treatment plan. Food that causes obesity also leads to caries, and following a healthy diet is the advice given by most dentists. An organization called Super Chefs built a program to teach healthy eating for athletes. Preventive methods include using a helmet that lowers the risk of dental and skull injuries, using face masks with face guards, using mouth guards reduces the risk of dental injuries. Other methods include lip guards or protectors, chin cups, and proper coaching and technique. And when it comes to mouth guards, it is a resilient appliance and also protects the brain from concussions. There are three types. Stock mouth guard that fits loosely over the upper teeth. They are not individually shaped. Boil and bite mouth guards can be individually shaped, however, they are subject to bite-through problems and are not as strong as custom-made mouth guards. Custom-made mouth guards are made by a dentist. It provides better protection, comfort, and are more likely to stay in the mouth compared with other models. They're fabricated using EVA and PU sheets. Steps include taking the impression, lab fabrication, trimming and polishing, and placement. There are many types such as junior, light, heavy, which offers different level of protection for the use of different sports. Initiatives taken in this field include aligning dentists with sports teams where the athletic trainers were adequately explained about traumas. An associate clinical professor at Texas introduced the first sports dentistry course into the curriculum. Screening camps for disabled athletes, a program formed by Special Olympics to provide awareness towards oral health and involves free dental screenings. Let's look at a case study of a hockey player that was hit in the face with a hockey stick, resulting in a fractured tooth and TMJ dysfunction. Treatment plan included repair with a dental crown, fabrication of custom-fitted mouthguards, and TMJ therapy. Recent advancements include the use of smart mouthguards with sensors, dental trauma simulators, laser dentistry for quicker treatment, telehealth offering remote consultations, performance monitors to track oral health such as bruxism and facial electromyograph to measure activity of muscles on the face. In conclusion, sports dentistry is an important aspect of sports medicine. Orofacial injuries are largely preventable through various methods. It's not just about fixing teeth, but also about protecting the athlete and ensuring the long-term oral health, well-being, and success. As we continue to push the boundaries of sports performance, let's not forget the importance of protecting our smiles. Thank you.
Very well articulated, doctor. And this is a coming up field right now and a need of our, because many of us want our our children to perform activities like sports and all, and we would want their safety also. So you can have a career in sport dentistry from now on. That is what is the lookout for all of us. So Dr. Vaishali Das, do you have any question for her?
No, not really any question. Very well presented, Shefali.
Thank
And yes, you can, now the dentists are diversifying. So this is
Yes,
a very good field to go into. Everyone who ever passes out need not do clinical dentistry.
Yes, ma'am.
Good job.
Very
Thank
good.
you, ma'am.
Rumpa?
Totally agree with what Vaishali says, because this is a completely nice ongoing field and time to diversify. And I love the way you collated the all of the material and present it to us. Very well done, Shefali. Very well done.
Thank you, ma'am. Thank you so much.
Dr. Sumita?
Yeah, concur again with Aisha. The time is for diversification, and endodontics does cover a lot of post-traumatic injury cases. So maybe preventing those traumatic injuries is the way to go ahead.
Great. What I would suggest is we'll finish with another other two presentations for poster, and then we'll go back to the students who were presenting papers who could not present that time. So, Dr. Shifa Uzma, are you there?
Yeah, one second. So I would like to add one more thing just came to my mind because I see so much of trauma. I feel such mouth guards need to be given to people who go to water parks and
Yes.
what do you call fantasy parks like Excel World and all. So many trauma cases I see, and removing the premaxilla is usually totally comminuted.
Yes.
Yes, ma'am.
So many cases.
Ma'am, in fact, that's what I'm saying. Having a tomboy daughter, I know that I think every child should have a sport card on.
No, I'm talking about these fantasy parks.
I know, but
So
then
many cases of trauma I've seen,
Yes, ma'am.
especially in the water park, because they come and they kind of bang on, collide onto the pond and fracture their entire maxilla. I feel something should come up for that also. Next time, whoever are the kids out here can take up that topic.
Yes, ma'am.
Wonderful, wonderful, lovely.
Yes, ma'am.
So, yeah, that's what that's a need of our actually. Dr. Shifa Uzma, are you there, doctor?
Yes, ma'am.
Can you, yeah. Dr. Shifa?
Yes, ma'am.
Yeah, can you start your camera, please? Yes, I can see you. Okay, so what I would want you to do is start sharing your screen immediately.
Is my screen visible, ma'am?
Yes, it is very much visible.
Can I start, ma'am?
Yes, please go ahead. Your time starts now, dear.
Good evening to everyone present here. Today, my topic is on geriatric dentistry. As our population ages, the field of geriatric dentistry plays a vital role in ensuring the oral health and overall well-being of older individuals. Here, we explore the unique challenges faced by the elderly in maintaining good oral health, the common dental problems prevalent in the demographic, and the effective treatments and strategies employed by geriatric professionals. The aging process brings about various changes in the human body, including the oral cavity. Geriatric dentistry, a specialized branch of dentistry, focuses on addressing the specific oral health needs of older individuals. As individuals age, maintaining good oral health becomes increasingly important, not only for the individual reasons, but also for the overall quality of life. Common dental problems in geriatrics faced by the elderly is the increased susceptibility to periodontal disease, xerostomia, dysphagia, dysgeusia, and burning mouth syndrome, edentulism. Consequences of edentulism are resorption of alveolar ridge, reduced chewing efficiency and limitation of food selection, speech impairment, change in appearance, psychosocial impacts, and reduced quality of life. Factors such as decreased salivary flow, medication, and systemic condition contribute to a higher risk of gum problems. Additionally, tooth decay and cavities remain a concern, emphasizing the need for preventive measures and regular dental checkups. Tooth loss, whether due to decay or other reasons, can significantly impact an individual's ability to eat and speak, affecting their overall well-being. Treatment approaches. Geriatric dentistry employs a comprehensive approach to address these issues. Regular and thorough oral examination are crucial for detecting problems at an early stage. Non-surgical periodontal treatments such as scaling and root planing are employed to manage gum disease effectively. Restorative dentistry techniques, including dental fillings, crowns, and bridges, aim to preserve or replace three, enhancing both function and aesthetics. Oral hygiene education includes oral hygiene practices, which is fundamental aspect of geriatric dentistry. Dental professionals tailor their advice to the specific needs of elderly patients, emphasizing the importance of maintaining a regular oral care routine. The education not only prevents dental issues, but also empowers individuals to take an active role in their oral health. Collaborative care. Geriatric dentistry recognizes the interconnectedness of oral health with overall health. A collaborative approach involving dentists, medical professionals become crucial in providing comprehensive and coordinated treatment plan. a case study of an 80-year-old woman with multiple chronic conditions, including diabetes, hypertension, limited mobility, limited mobility, mild cognitive impairment, periodontal disease, and edentulism, dry mouth due to medications affecting saliva production. Strategies implemented to treat this: comprehensive geriatric assessment, collaborated with the patient's medical team to understand overall health, identified the potential barriers to dental care, individual treatment plan, prioritized oral health issues based on urgency and patient comfort, adjusted treatment modalities considering medical conditions. Innovation and future directions. Advancements in technology play a significant role in shaping the future of geriatric dentistry. Teledentistry, for instance, enable remote consultation, improving accessibility for older individuals. Ongoing research focuses on innovative treatments and interventions specifically tailored to the unique challenges presented by aging. In conclusion, geriatric dentistry stands at the forefront, promoting a healthy and functional oral cavity for older individuals by addressing common dental problems through comprehensive approaches. Oral hygiene education and collaborative care. Geriatric dentistry contributes not only to the preservation of teeth, but also to the enhancement of overall quality of life in our aging population. As we continue to embrace advancements and innovations, the future of geriatric dentistry holds promise in providing tailored and effective healthcare for the elderly. Thank you.
Wonderful poster, Doctor. And I would like to ask Dr. Vaishali Das if she has any questions for her.
No, not really. Very good presentation, Shifa. And
Thank you, ma'am.
that is the need of the hour, because we are also seeing so many issues with the geriatric patients nowadays, and handling them is not a joke for themselves and for the caretakers. So this topic needs to be implemented well. Good job, though.
Dr. Sumita?
I like the poster very much. The like Dr. Vaishali said, it is the need of the hour. Somewhere, just maybe just a side note that sometimes I feel that orthodontists are such lovely counselors, because these old patients, they need so much more than just dental treatment, and often prosthodontists can be that kind ear, and so it's a very important part of a prosthodontic practice. I feel. So good job, nice.
Thank you, ma'am.
Dr. Rumpa?
Hi, Shifa. Just love what you did. And rightly said by my two predecessors that it's the need of the hour. And there's a difference between tier 1 and tier 2 cities, if I may say. I'm in tier 2, I'm based in Bhopal. So sometimes what I do is when I get a call from a patient who cannot walk or do too much, I do a home care. I go home, I take my little kid first, check them up. And so that is possible, I think, in small towns and cities where the distance, in here, you can reach anywhere in 20-25 minutes. Bombay, whenever I have to travel from one place to the other, it's like I have to keep 2 to 2.5 hours on hand, beating the traffic, everything else. But yes, it's a good job and it's the need of the hour. Absolutely. There are patients waiting, but what do we do for them? What can we do for them? Not what do we do, what can be done. That is more important. Hats off, girl. Hats off.
Thank you, ma'am.
Wonderful, Dr. Now we have Dr. Sanvi with us. Is she there? Are you ready with the presentation now, dear?
Yes, ma'am.
Okay, and I think your mentor would also want to join you. Was that the thing? What was it, Dr. Shrisha? Are you? Just do one thing, Sanvi. One thing at a time. Just switch on the camera, dear.
Yes, ma'am.
Okay. Now start sharing your screen, dear.
Is it visible, ma'am?
No, not yet, but yeah. Now don't, go on the presenter's mode. Yeah. Just little more bit on the right, your cursor. Go on the presenter's mode if it is possible.
Is it visible, ma'am?
Yeah, just click on that button. It's not happening? Okay, do one thing. Present as is. We are able to see your poster. Best of luck and don't get scared. You want to drink water?
No, ma'am.
Okay. So all the best and start sharing. Start your presentation. Your time starts now, dear.
A very good evening to everyone. This is Sanvishri. I would like to present my topic on effect of tobacco on women's oral health because this topic delves into the multifaceted relationship between the tobacco and women's oral health. So coming to the introduction, women. Coming to the introduction, present topic, women when they consume tobacco, they are likely to suffer with increased likelihood of oral cancer and gum diseases, malodor which deals with bad breath, and increased accumulation of tartar, which is plaque forms on the tooth, and stained or discolored tooth, and dental implant procedures failures, and gum diseases like gingivitis and etc. So more women usually suffers with the reproductive system than men. They have more irregular painful periods, have low estrogen level which can deals with the mood swings, fatigue and vaginal dryness, and they have really very trouble in getting pregnant. Well, coming to the respiratory issues, uh, women smokers are more likely to get the uh, chronic obstructive pulmonary diseases. It is a lung disease, and the women die more due to this disease. And coming to the cancers, we all know that how women are suffering with various cancers such as pancreatic, kidney, lung, breast, and rectal cancers. Um, and there are more increases in cervical cancer. Quitting lowers your risk of getting certain diseases in future. It's never too late to gain the benefits from quitting. Smoking and pregnancy deals with high risk of being born too early, and lowers the chance of healthy birth weight, and the born baby has less likely to have normal brain development before the birth or through overall their childhood. Women who quit smoking are making a healthy choice for themselves and their baby during the pregnancy and birth. Quitting smoking lowers the risk of miscarriage and ectopic pregnancy. Preventive measures we take are prohibition of the smoking in the public, and we encourage everyone to be educated and spread awareness and create a tobacco-free generation. So there are many treatments, and mainly we consider a medical treatment and the behavioral treatment. Medicinal treatment, we go with the nicotine replacement therapy, and I conclude it with the quitting is good for your so quitting tobacco is good, and don't let tobacco destroy you. Start from destroying tobacco. Quit tobacco today to live young tomorrow. Thank you.
Great, Dr. Sanvi. And Dr. Rumpa, do you have any questions for Sanvi? Sanvi, drink water first. And don't be
Sanvi,
scared.
hi. Again at second year, amazing job. Amazing job. Second year, amazing job. So, tobacco impact on women health, absolutely. And I like what you described. Just one point. When we started presenting, there was nobody to guide us. We did this, we did that, we dived, we did so many things, and maybe still not. I can't say I'm perfect. No, I'm still learning. So, what I wanted to point it out is when you present a poster, instead of writing paragraphs, make points. It's easier for the judge and the other people to see 1, 2, 3, 4 or bullet points. It will be easier. Just a little tip. Otherwise, wonderful job.
Wow. Coming from Dr. Rumpa Vig, I would say these are all pearls of wisdom. You should always collect them and they will definitely help you, dear. Dr. Vaishali Das.
Yeah, Sanvi, very good. Good presentation. And again, the same thing I was going to inform you about the bullet points, because when it is a paragraph, you can't just read through it. It becomes a little difficult, but well done. And it is the need of the hour again, because nowadays we see too many girls smoking around. So, yeah, they do not realize the impact on their life, whether boys or girls, whoever it is. We need
Yes.
to help them quit smoking.
Yes.
Good.
Dr. Sumita?
Just to go a little bit ahead on what Vaishali said, that when girls smoke, they not only endanger themselves, but they endanger the life that they potentially carry later. And low birth weight babies have been associated with smoking women who have quit also. So, they aren't responsible for just their own health, but also for the health of the unborn that they may someday have. So, I mean, I think one of the greatest responsibilities that we have as a woman is that we are responsible for creating life within us. And that responsibility, I think many of us uh, don't take as seriously as we should. So yes, tobacco usage in a woman doesn't harm one, but harms two or more. Yeah, good presentation.
So it's more about considering the permanent damage that we are doing with regards to the temporary excitement or fun what we are having. Very good presentation. Now we have Dr. Sanmati S. Are you there, Dr. Sanmati? Dr. Sanmati, are you there?
Dr. Sonal, she is not available here. We can
Okay.
go with Dr. Thilaga, the PG
Thilaga, are you
presentation.
there now? Dr. Thilaga?
Ma'am, I am there. I'm just trying to
Yes.
share the screen.
Yes. Can you switch on your camera? She is a student and presenting a paper presentation. So we go back to her.
Yes, ma'am.
Yeah. From Savita Dental College.
I guess you're a first year postgraduate student, right?
Yes.
Ma'am. I'm a first year postgraduate student, but sorry for wasting your time. My screen, I'm just clicking the green button, but it is not showing me the files. So sorry.
Don't worry, Tilaga. It's okay, happens.
Not able to. Sorry for wasting your time also, that's all.
I can see Dr. Juhi around now.
Yeah, though she is playing hide and seek with me. I don't know why. Dr. Juhi, why are you playing hide and seek with us, dear? Can you come online? Can you start sharing? Just switch on your camera, dear. Let me see you first. Dr. Thilaga, any progress?
I'm trying my level best, ma'am. Sorry.
Don't say sorry. Don't have to be sorry about it, dear. Happens to all of us. We have Dr. Suganya with us, faculty from Savita Dental College. Are you there, Dr. Suganya?
Yes, ma'am.
Okay, Dr. Thilaga, do you want to take a minute and Dr. Suganya will present? Is it okay? Dr. Vaishali Das, Dr. Rumpa Vig, and Dr. Sumita Lele Bhagwat. Dr. Suganya is from Savita Dental College and she requested to be a part of this Congress at the last minute. And we are just, I would request you to wait for 10 more minutes and listen to her, please. Dr. Suganya, can you start your camera, please?
Yeah,
Yes, ma'am. It's already on. Can you see me now?
Yes. Can you share the screen, Doctor?
Yes, ma'am.
Lovely seeing you.
Thank you so much. Thank you, Sonal ma'am, for.
Yeah, Dr. Sumita, were you saying something?
Yeah, is this a faculty paper, non-competitive?
Faculty, non-competitive faculty paper.
Yeah, okay, okay.
Yeah. Dr. Suganya, continue, please.
Yes, ma'am.
Yeah. Your screen is
Ma'am,
visible.
is my screen visible, ma'am?
It's visible. Can you go on a slide share mode, please?
Yes, ma'am. Ma'am, is it okay now, ma'am?
No, no, no. Your slide is still not shared. But what you can do is maybe you can start presenting in the same mode. Press escape. If you're seeing a full screen on your screen, please press escape. Go back to the presentation and start presenting. Go on a slide share mode if it is possible. Top top hand column, you have it after undo. Up.
Yes, ma'am.
Yeah.
Now, ma'am?
No, dear. No,
Can
dear.
she try, Sonal, from the footer?
The
That is
footer,
much
yeah,
easier.
there's a footer down. You can see
You
the
can see on the right hand side
right
that
hand side extreme column.
slide show, it will show you better.
That minus sign, you're seeing, Dr. Suganya.
Yes,
Okay.
ma'am.
Yeah, again start share screen. Start with your share screen. Okay, now go.
Now, can you able to see, ma'am?
No, press the slide share button, right? Go on the right, extreme right corner, you go. Okay, press there.
Yes, ma'am. From beginning.
From beginning, yeah. Mm-hmm.
Is
Okay,
it visible now, ma'am?
no, go back. Go back.
Okay.
Okay, and present it as is in the presentation. What you're seeing now, present it that way only. Okay, we are able to
Okay,
see
okay.
the screen. Okay, so manually
Ma'am,
you
is
go.
it visible now if I don't
Yeah,
go with the slideshow?
yeah, it is visible. Please continue.
Okay.
Your time starts now, doctor.
Yes, ma'am. Yes. I would like to, good evening, everyone. I would like to present a research which we did during COVID. It is the assessment of female hormonal influence on COVID-19 vaccine response, which is a prospective cohort study. And we all know that coronavirus is a deadliest pandemic which spreads through infectious particles due to sneezing and coughing. And thus, salivary secretion is remained as a primary source of infection. And the whole commencement of these symptoms starts in 2019 in Wuhan, China, and still it is proceeding. And why this gender-based investigation is because the previous study suggests that this concentration of ACE2 in the men's blood is higher than females. So most of the studies were pertaining to the other systemic systems, but not with the reproductive system. So our main idea was to focus on the reproductive system. And moving to the antibodies, since the oral cavity has various receptors for the activation of the virus, we are more pertaining to the antibodies IgA and IgG. And IgA is the one which is present in the 1 week of infection onset, but later it is getting declined within the 4 or 6 weeks. Whereas IgG were raised up to 9 months, and hence we chose IgG for our study. And the cortisol on the COVID-19 patients exhibit a greater acute cortisol stress response, and it is also considered to be the physiological indicator for the stress. So, since the stress levels and the menstrual cycle are intrinsically linked, we also wanted to find out the cortisol levels in the menopausal and people, women who is having the normal menstrual cycle during the COVID infection or after vaccination. So, hence, the aim of our study is to analyze the levels of IgG antibodies, total antibody, and cortisol in the unstimulated saliva of women with normal menstrual cycle and most menopausal women, in order to emphasize the influence of SARS-CoV and the effects of COVID-19 vaccination on the female reproductive system. So we had 88 participants. Randomly, we picked them, and among them, 39 were the women with a normal menstrual cycle, and 49 women had menopause. Among them, 4 were non-vaccinated, 15 were vaccinated, and 3 received COVID. 3 had got COVID infection. 2 received COVID infection before, I mean, after the first dose of vaccination, and 1 participant had COVID vaccination. COVID infection after 2 doses of vaccination. So we calculated the IgG, total antibody, and cortisol levels with the ELISA. Then the results were the COVID-19 infected women have more IgG antibodies, and however, the total antibody levels in postmenopausal women were lower, and the postmenopausal women have the higher cortisol. As I mentioned, the COVID-19 infected women have more IgG, and also the women who receive 2 doses of vaccination also have more IgG levels. And the postmenopausal women have higher cortisol levels, which is due to the glycosylation of the IgG, which is happening. And it is all, as already mentioned, the cortisol and the hormonal of the female hormones are intrinsically related. And moving to the discussion part, COVID-19 infection has long-term effects on numerous physiological systems, but there are only few studies to establish the effects on the female reproductive system. So, and moving to the cortisol and the COVID, due to the similarity between the amino acid sequences of ACTH and the SARS-CoV vaccine, the antibodies render endogenous ACTH inactive and eliminate ACTH secreting cells. There were many studies which states that the COVID-19 infected patients had necrosis of the adrenal cortical cells. And in our study, patients who tested positive for COVID-19 had higher cortisol levels than the person who tested negative, according to the previous research. And hence, higher cortisol levels are considered to be a measure of disease severity because they increase mortality. In our study, cortisol levels in women usually rise during premenopause and menopausal because the conversion of the estradiol to estrone. In our study, menopausal women had higher cortisol levels than women with normal menstruation, indicating that COVID-19 vaccination doesn't have any role over the protection of higher cortisols. Moving to the antibodies, IgG antibodies are preferred over IgA and IgM antibodies because their levels remain elevated after infection for a prolonged period of time. And in our study, patient who recovered from COVID-19 had higher IgG levels, and also patient who had infection had higher IgG levels when compared to the normal person with the which who doesn't have the COVID-19 infection. And also, normal menstruating women had higher antibody levels when compared to the postmenopausal women. And numerous studies suggested that the estrogen facilitates the glycosylation of IgG. Hence, consequently, the postmenopausal women have higher IgG levels, which is consistent with our findings. And in addition, IgG levels had increased following the second vaccination dose. So, the vaccination against COVID-19, along with the female hormonal influence, contributed to the development of humoral immunity in females. And the effects on the menstrual cycle, previous studies had reported that there are changes in the menstrual cycle, and many, among 5%, have the complaints of unanticipated vaginal hemorrhage. However, the immunological influence on female hormones or the immune cells in the uterus during the menstrual cycle or the activation of immune cells in the uterine lining could be the cause of immune stimulation in menstruating women, explaining their immune response among them following vaccination is greater than in the menopausal group. And in our study, no patient in our study who received COVID-19 vaccination reported any menstrual irregularities like unanticipated vaginal hemorrhage or any changes in the due course of the menstrual cycle. So to conclude, the saliva can be used as a preliminary sampling to diagnose and monitor COVID-19, and it also can be used to do a long follow-up, and it is also the simplest technique to derive. And this study mainly focuses on the measurement of the cortisol and antibodies as well as the long-term effects of the COVID-19 vaccination in females. After vaccination, female hormones protect against COVID infection via cortisol regulation and the IgG antibodies. These are my references. And thank you everyone for this opportunity. I personally thank Dr. Sonal ma'am for this opportunity. Happy Women's Day.
Thank you so much, Dr. Suganya. And Dr. Vaishali Das, do you have any questions? I'm sure you have many.
No, actually, I don't have any. Because giving more of an information to us, I have
Yes.
not really thought about it because during COVID, whatever injudicious or maybe judicious also use of steroids have caused a lot of issues during that time. We have seen surge of cases of mucormycosis, and we were so drowned in that we never thought about these things. So thank you for this information. And being an oral
Thank you, ma'am.
surgeon, we have been thinking from a different, from the rehabilitation part all the time. Never thought about this. Thank you for this information, though.
Thank you so much, ma'am. Thanks a lot.
Arunta?
Wonderful learning curve for me. Awesome study, and I'm glad you presented this. It really took us to a different level, what is happening inside after the COVID vaccine, etc. Thank you for that.
Thanks a lot, ma'am. Thank you so much.
Sumita?
I concur with both my colleagues. Lovely presentation and yes, a learning curve. It's always good. It's always a good day when you've learned something new. Thank you.
Wonderful.
Thanks a lot, ma'am. Thank you.
Yeah, glad you could join, Doctor. And Dr. Thilaga, last chance for you, dear. Can you come online? We would really want to listen to you.
Yes, I am ready now.
Can I suggest something, Dr. Sonal? Oh,
Yeah, no,
good.
she's done.
Okay.
She's done.
Okay.
She's already done.
Yeah.
Okay, Dr. Thilaga, your time starts now.
Yes, ma'am. Good evening, everyone, and thank you for your questions. I am Dr. Tilaga, doing my first MS in oral biology at Savitha Dental College, Chennai. And my topic is female preponderance of oral mucositis and institutional experience. So mucositis, as the name suggests, is an inflammation and ulceration of mucosa. Any mucosa, oral, the pharyngeal, the gastrointestinal, or any mucosa which gets inflamed and ulcerated, we call mucositis. When it happens in the mouth, we call oral mucositis. And when does this oral mucositis happen? It's the most common side effect of cancer treatments, like chemotherapy and radiation. So what does it cause? It causes redness, swelling, and painful sores, making it difficult to speak and eat. So the quality of life of the cancer patient is much reduced during this treatment of cancer. So how are they managed? Management is just the supportive care, dental hygiene, and pain management. So when we go deeper into the gender prevalence within the oral mucositis, particularly the cohort of the cancer patients, there is a study by Okurka et al. He says that females have a higher incidence of oral mucositis compared to men. So when we talk about females, we know the first thing which comes into our mind is the hormones. So what the study says is there is a hormonal variance between males and females. So the females are more prone to oral mucositis. And there are other variables like hereditary variables, which causes a difference in the makeup of saliva and the oral tissues. So studies point out to a possible connection between the oral mucositis and the estrogen levels during the cancer treatment. So according to certain researchers, the premenopausal women who have a greater estrogen levels have a protective impact that reduces the risk of oral mucositis, or the lessens its severity. So here in our study, this study was carried out using the clinical data taken from the cancer patient records in the institutional DIAS platform, Savitha Dental College and hospitals between 2019 and 23 with ethical clearance. A total of 120 cancer patients were taken, out of which 50 were female and 70 were male. So approximately around 41.6% of the cancer patients were females. So the statistical analysis, this study is full of statistical analysis, which was done using the SPSS software and the Orange AA software. And here we can see there is a nice difference seen with the female cancer patients and the male cancer patients who developed oral mucositis and who did not develop oral mucositis during the cancer treatment. So though the female counterpart were less in the cancer group, the oral mucositis is more in the female side. And we did a lot of statistical analysis to find the distribution of oral cancer, first of all, and then how the oral mucositis distribution. So oral mucositis was found in 65.8% of cancer patients who received the treatment. But 34.2% of the cancer patients who received the treatment did not have and develop any oral mucositis during the period. So when we see the gender and the oral mucositis correlation, we see that out of 50 cancer patients, female cancer patients, 42 people developed oral mucositis, but in male counterpart, it is much less. So there was a significant correlation where the p-value is less than 0.05. And this is a seed pattern. So we try to compare the age and the oral mucositis to find whether the age is playing an important role in oral mucositis. Here we can see all are equally distributed. There is no significant correlation between age and oral mucositis. But on the other hand, on the right side, if you see, there is a correlation between gender and oral mucositis, where the female counterpart are having more of oral mucositis during the cancer treatment. So this is also a statistical distribution of oral mucositis and the gender. The left half shows the female cancer patients and the right shows the male cancer patients. So the cross tabulation, what we found in the statistical analysis, shows a p-value which is very less than 0.05. So it is a significant association between gender and oral mucositis. So females tend to have a higher incidence of oral mucositis than the male counterpart. The hormonal changes in women play a fundamental role in the etiopathogenesis of oral mucositis during autologous peripheral stem cell transplant therapy. This study was done by Gebri et al. In 2020. Their results indicate a predominantly negative effect of female sex hormones on oral immunity, with a role in the etiopathogenesis of oral mucositis. So hormonal factors, when we talk about hormones, we first, for females, it is estrogen and progesterone. So what does this estrogen and progesterone do on oral mucosa? It may influence the immune response and inflammatory process in oral tissues. That is the reason the estrogen progesterone levels are altering the response of the oral mucosa towards the radiation. And there are cytokine and growth factors, insulin-like growth factors, which are also playing an important role. For a cell, when it is damaged, it has to regenerate and repair on its own, but that signaling pathways are hindered by due to the these imbalance in these factors. And cortisol, which is not gender dependent, but that is also causing a shift in the oral mucositis in cancer patients. So this is the outline of oral mucositis and the gender prevalence. So the multivariable analysis done by Okurka et al. Says that the female patients are gender is an independent factor, risk factor in the oral mucositis. And the researchers suggest that there's a possible connection between estrogen and oral mucositis, and there are genetic variables also which affects the inflammatory pathways and immune response, how a patient responds to a treatment. So all these things contribute to the oral mucositis towards the female side part. So in conclusion, we have to understand the genetic basis of oral mucositis, which could help predict and treat the condition more accurately, especially in female cancer patients. And future research is needed in this field to enhance the quality of living of patients undergoing cancer treatment. So these are my references. And thank you so much, and thank you for your patience, and a very happy Women's Day.
Yeah, thank you, Doctor, so much. And Dr. Vaishali, I'm sure you have some questions for her.
Excellent study, Dr. Tilaga. It was worth the wait, and got to learn a lot of things. And we definitely know in cancer patients, post-radiation, especially mucositis, is very common. So, though this was a comparative study, a statistical study, but what do you do when the mucositis happens? We need to see we all know that mucositis happens. So what is the treatment for that you all follow? What protocol you follow?
First of all, we prescribe antifungal treatment, ma'am. Topical antifungal treatment is prescribed to prevent the candida infection or fungal infections. So that is the first thing which is done. And in case of any dry mouth, xerostomia, wet mouth, or artificial salivary substitute, we have to give them palliative treatment for the pain or all those things. So we have to go more into the genetics and try whether the patient is susceptible to oral mucositis, what is the reason behind this oral mucositis, especially in the female patients, and if needed, any hormones can be supplemented, and future research we have to dive deep into.
Yeah, because your paper is sort of a continuation of a paper being presented earlier for hormone replacement therapy.
Yes, ma'am. Yes.
Good presentation.
Thank
you so much.
Dr. Rumpa, do you have any questions for her?
No, not really, because never delved into oral path after graduation. So these are all, again, some new chapters opening up, and fantastic to go back there, and wonderful, wonderful. Really liked it.
Thank you, ma'am.
Dr. Sumita?
I'm going back very enriched today, so.
Yeah, again, a learning curve for me, mucositis is something that doesn't come up in my line of work at all. So I'm happy to learn, and I'm Shani is there to address it.
Lovely, lovely.
Dr. Tilga, one thing I have been doing, not documented anywhere, just telling what I'm doing. Basically, I have no research. I'm not a research-oriented person at all. Okay, so what I always tell my patients, this is for the benefit of everybody, if someone comes across this kind of patient, very simple thing, a home remedy like glycerin mixed with little water. If the patient just gargles it in the mouth 3-4 times a day and maybe just take it and apply it all over the mucosa and the tongue, I've seen it helps big time. Because the wet mouth and all, it does help, but it's not available everywhere. Again, when we talk about the rural areas, again, like Dr. Rumpa said, the tier 2, tier 3 cities, it's very difficult to get all these hi-fi salivary substitutes. You are in Chennai, again, metropolitan city, you will get it, but smaller cities don't get it. So just plain simple glycerin and water all over the mouth, it helps big time.
Thank you so much, ma'am.
Okay, great. So I think we have already finished all our paper presentations, faculty presentation, and the undergraduate and poster presentations and everything. So I would like to extend my heartfelt gratitude, thank you to all the jury members, Dr. Vaishali Das, Dr. Sumita Rele Bhagwat, Dr. Rumpa Vig, and everybody out here who were present, and all the presenters. First of all, I would say that this was a very, very brave initiative. Ask me, I still shiver when I go on stage to present anything. And I have my mentors here who have witnessed that also. So take a bow, every one of you, each one of you deserve a clap. So winning or not winning, that's a different issue altogether. And I would like all the mentors, the jury and the Dr. Rumpavik also to switch on the mic and say a few words of encouragement for to all the speakers. I'm sure you have already said your bit, but Dr. Rumpa, please.
Yeah, overall, this was mind blowing because the choice of topics and how it was kind of brought to us in front today, Pdcon first day, amazing. I loved it. I loved it. So from 3 o'clock to right now, it's what, 7:24. I have been glued to my seat.
Yeah, that says it
So
all.
that's amazing. And hats off to all these beautiful girls. And I can see Ashwini here again. Ashwini, thanks for starting the OGG, Original Girl Gang. Absolutely wonderful. And join us and let's grow together. Let's move together and let's share what we know. Personally saying, I learned a lot today.
Wonderful, ma'am. Dr. Vaishali?
Yeah, again, Dr. Rumpa has already said it all. But yes, it was really amazing how nowadays they get so much of exposure, and a lot more is still needed. I feel some other colleges, in fact, those who have not participated, have missed something. It was an amazing arrangement. Everything went off really well. For those who had little technical glitches, please don't worry. It all happens in such conferences, and don't feel bad about it. And that is not going to affect your marks or your judging whatsoever. You all have done a fantastic job, and we who have been glued to our fields, in fact, we have learned a lot. We are more enlightened today because we have gone back to the basics, and it has really helped us. Thank you so much for being here for us and enriching us.
Thank you, ma'am. And Dr. Sumita?
Since I've been in teaching for so long, I'm really glad that girls are now coming ahead and exploring, platforms and fields which, they build up their confidence, they build up their presence, an aura that they create for themselves. And interestingly, dentistry is very dominated by women. Most of the colleges are now showing 80% of admissions women, girls, and 80% of the faculty is women. So by by encouraging girls and young ladies to come forward and providing a platform for them to be able to speak. We are not just encouraging tomorrow's girl, but we are also taking dentistry to a new level. So, all those girls out there who have presented, who have done papers and posters, while, it was very thrilling that you looked up to us as jury and madams and things like that. Believe me, we look up to you as the future of dentistry for us, because maybe 10, 12 years and we're going to hang our boots. So it's good to know that we're leaving dentistry in good hands. So good job.
Yeah, thank you everyone. And this was day one of PDCO, and that is Pink Dental Congress day one. And I'm sure everyone is enlightened and enriched, and we have so much to look forward to. And in a way, somewhere I feel good that when I started my thought process behind this Congress, that am I doing justice to the younger self? And I'm seeing these young girls presenting so well. They are the future, of course, as you all have said. And I'm sure we have learned a lot, as all the mentors and all the jury members have said here. But one thing for sure, look forward to tomorrow, wherein the middle age comes into picture, and they will be guiding us all about what you can achieve being a dentist, being a mother, and being yourself, how the self discovery has helped them. So looking forward for tomorrow. I'm thrilled because I want to be a part of this web series. And the episode 1 starts tomorrow itself. And tomorrow, only thing is that we will be starting a little early at 1:30 ish, because if there are any presentation that are pending, I would like to hear them out also. We are giving a fair chance to everybody here. And I would tell all the presenters who are present here that the jury was kind enough to take in all the presentations that had come from the students. They said, we will wait, we are there, we will listen to them. It takes heart, it takes efforts, and it takes so much of I would say dedication to listen to all these young bees. And it has taught us, of course, but I would say you all should be thankful that the jury all give you all an opportunity here. And thank you, jury, thank you, Dr. Rumpavik, for always being there. And I'm looking forward to tomorrow, and I would request everybody to be there tomorrow, because I need your support. I'm also your student, so I will need your support. And it's a request, and please be there. And looking forward to you all tomorrow. And episode 1 starts at 2 o'clock, wherein we have the pioneer, as Dr. Rumpavik says, the OGG, Dr. Ashwini, who is actually the founder of Dental Divas Group. She brought together a few dentists. She women dentists. She started a Facebook group, and she has amalgamated everybody together. She is that sweetheart whom we always look overhead to. And she
Can we
is
see her?
Dr. Ashwini
Can we
Pujari.
see
Are you
you?
there? Please switch on your camera. Dr. Ashwini, I think she must have left, or but yes, tomorrow. Yeah, she is there. Dr. Ashwini.
Yes, mamas, I'm here.
Yeah, please switch on your camera, dear. We want to see you.
Okay, one, give me a sec.
Okay. See, Dr. Ashwini Pujari started this Dental Divas group, and she brought together. We started with 10 divas, and now the family is expanding, and it has become a more of a mentorship program in itself, because every day you will see something or the other getting uploaded by mentors. Ashwini, can you please switch on your camera, dear? We really want to see you.
I have switched on. It's
Yeah,
showing.
yeah. Now we are
Can you
seeing.
see?
This is
Can you
this is
see me now? Yes.
Hey.
I have watched all the paper presentation and poster presentations of today, and it is a pleasure to see all the young minds sharing such a knowledge. It was a privilege to watch, and I was observed all the posters also. This is the first time I'm watching any poster presentation, so the explanation and the review and the questioning, everything is awesome. Thank you so much. And thank you, Dr. Sumita ma'am, Dr. Rumpa ma'am, Dr. Vaishali ma'am.
Very good. So Dr. Ashwini will be starting. She is the trailblazer for us, and she will be the flagship holder for. And her topic for the day would be networking beyond dentistry, something which every one of us should know.
Yes.
How to present yourself.
Yes,
So looking
exactly.
forward for tomorrow, and see you all at 1:30 tomorrow, because we will be taking in few paper presentations, pending paper presentations. So please join us little early, have a good lunch and have a good night's sleep so that your mind are fresh to join us tomorrow. Okay, so see you all tomorrow. Till then, stay tuned. Bye. This is Dr.